Okay, so all right. So before we start, this is the format for those who newly join. For the new case, new format, be given 9 minutes for history taking. This is the suggested uh, time frame for you to prepare. 4 minutes to examine patient, 2 minutes to address the patient concern, and also 5 minutes for Viva. So if you are ready, your 4 minutes starts now.
Okay, doctor.
Okay, 4 minutes, sir.
Yes, doctor.
All right. So okay, start now.
Mm. Hello there. My name is Dr. Rabi, one of the doctor in this clinic today. Is this Mr. John, 27 years of age?
Yeah, I'm John here.
How may I address you today?
You just can call me John.
Okay, John, we are here to discuss about your health condition, following which I will be examining you and then I'll be able to address your concerns. So, did you our conversation? I'll be taking some notes, and I promise it will remain strictly confidential. Is that okay for you, Mr. John?
Yeah, sure.
Okay, Mr. John, I went through the notes and I found that you've been having this palpitation for 6 weeks. Is that so?
Yeah, it has been there for the past 6 weeks.
Can you tell me more about it, Mr. John?
All right. So initially this palpitation, I feel that my heartbeat is I'm quite aware of my heartbeat. Started 6 weeks ago. Initially, it was like 1 week, maybe once or twice, but
Mm-hmm.
for the past 1 week, it has become more frequent that it occur daily now.
So it occurs throughout the day and night, or more specific time of the day?
There is no specific timing about when it will come, but I
Okay,
realized that for the past 1 week, it has been maybe 2 to 3 times every day.
every day. Okay, I'm really sorry, Mr. John, for your some symptoms, but let me try to help you. Can you please tell me that does uh, any activity trigger your palpitation?
There's I couldn't recall any specific activity that will trigger it because when I'm actually at rest, the palpitation will appear
Okay,
as well.
okay. And along with the palpitation, have you noticed any chest pain, chest heaviness,
No, there is no chest pain, there is no chest heaviness.
any shortness of breath?
No, there is no shortness of breath as well.
Okay. And have you noticed any headaches at the time?
Uh, no,
And dizziness, feeling of fainting?
no,
No. And feeling of like flushing, rashes over your face?
no.
No. And have you noticed, do you have any like, how many pillows do you use at night to sleep?
I usually sleep with one pillow.
One pillow. Okay. And okay. And you don't have any chest heaviness, as you said.
Yep, I mentioned it just now.
Have you noticed any loose bowel motions?
No,
Okay. And any cough?
no cough.
No cough. Okay. And have you had any feeling of sickness, like throwing up?
Not really.
Not really. And any feeling of shakiness of your fingers?
No,
No. And do you have any raised body temperature,
nope,
fever, any night sweats,
no,
any joint pain,
no.
any rashes over the body?
Not that I'm aware of.
Okay. And any change in weight recently?
My weight has been. You see, I'm actually quite. I see myself as overweight,
Okay.
so I've been trying hard to actually lose some weight as well recently.
You've been trying to lose weight.
Yep.
Okay. And have you lost some weight?
I'm actually trying hard, and I think recently probably I have lost another 2 kilo for the past 1 month.
Okay. 2 kg in 1 month.
Yep.
Okay. I see. And how is your diet and appetite?
Or I have been trying to restrict myself from eating much nowadays.
Okay. And what are your measure of the diet is?
Oh, most of my diet actually are protein and also vegetable. I seldom take carbs nowadays.
Okay. I see. Any weather preferences?
No,
Okay. All right. And how is your bowel work, John?
uh, I pass motion every day.
And how is your water work?
I would say normal.
Okay. And has anybody told you that you look pale recently?
No,
Okay. All right, Mr. John. So, okay. And have you had any like bleeding from your nose or in any parts of the body?
no.
No. Okay. All right. So, Can I ask you, Mr. John, if you have any previous medical condition?
Okay, I actually have this condition called sick sinus syndrome.
Okay.
Yeah, and it was like diagnosed 2 years back when I have the similar uh, problem where I am quite aware of my heartbeat that time. So
Okay.
actually, the doctor did some tests and also some lab tests. So subsequently, they actually suggested me to be implanted with a pacemaker.
Okay. Okay. And have you had the implantation of the pacemaker?
Yeah,
No.
I did.
Okay. You already did.
Yeah, it was 2 years back.
Okay. And when was your last follow up for this pacemaker device?
Oh, it was about 2 to 3 months ago.
And have you missed any follow ups?
So far, no.
No. Okay. And any medication that you're taking regularly?
No, I'm not on any regular medication now.
Okay. And any other previous surgeries done?
Only this pacemaker insertion implantation.
Okay. Do you have any drug allergies?
No,
I'm sorry for the next personal question I have to ask to all my patients. Any recreational medication or IV drugs?
no.
Okay. And any disease that runs in the family?
My father did have a heart problem, but he is still well now, and the
Okay.
doctor did mention that is a blockage in the heart.
Blockage in your heart. Okay. Any untimely death in the family members?
But then,
Have you had any history of any untimely death in the
oh no, no,
family?
not that I am not aware of.
Okay. And do you smoke?
I used to, but subsequently after the pacemaker implantation, I actually stopped smoking for the past 2 years.
Okay, very good. And do you drink alcohol?
No.
Okay. And what do you do, if I may ask, John?
Oh, I'm actually a clerk.
Okay. And is
Yeah.
this something that has impacted your work anyway?
Yeah, it definitely affect my work and my life because for the past 1 week, I have difficulty in focusing as well due to
Okay.
this awareness of this heartbeat, and I'm quite worried actually.
Okay. And Mr. John, have you ever passed out?
No.
No. Good. And do you drive?
Yep,
Okay.
I'm
All right.
driving.
Okay. And okay. So, Mr. John, can I examine you?
Sure.
Okay. So first of all, I will ask the patient to lie on this bed in 45-degree and ask and check the hand.
Hands, what would you like to look for?
I'm going to check for any tremor.
No tremors,
Okay. Any changes in the nail.
no changes in the nail.
Okay. And checking the pulse in both the hands.
It's regular pulse.
Regular. Okay. And I'm gonna ask the patient if the patient has any pain in the arms.
No.
I'm gonna check for collapsing pulse.
It's absent.
Absent. And checking the eyes for pallor.
No. No
Any
pallor.
features of hypothyroidism. Eye.
No thyroid eye disease.
Okay. And opening the mouth. Any any ulcers, any lesion inside?
No.
No. And have you ever had any dry mouth, Mr. John?
No.
No. Okay. And I'm going to check for JVP,
Mm-hmm. JBP is not raised.
not raised. I'm gonna I'm gonna feel the pacemaker leads.
You cannot. There is no scar on the chest wall.
No scar.
Yep.
And no pacemaker scar.
No pacemaker scars on the chest wall.
And the patient had pacemaker, right?
Yep.
Okay. And I'm gonna just feel if there is any lead that is palpable on the left chest.
No leads or battery box palpable on the left chest
On
wall.
the right chest,
No,
on the back.
no,
Okay, I'm gonna auscultate the heart. I'm gonna check for the mitral area,
mm-hmm.
for any
Heart
murmur,
rate is normal, no murmur, S1, S2 normal.
normal, and tricuspid area,
No
pulmonary,
murmur,
no
no
murmur,
murmur,
no murmur. Okay. Also now I'm going to auscultate the carotid area,
no bruit.
no bruit. Okay. So at this point, I will also want to check the lying and standing blood pressure of the patient.
Okay, good. Lying and standing blood pressure is normal. No discrepancy of more than 10
Okay.
millimeter
I'm going
mercury.
to check the thyroid from the back.
You mean you would like to check the neck from the back?
Yeah,
All
thyroid
right.
gland. Yeah.
Okay. No neck masses palpable.
Okay. And now I'm gonna listen to the patient's lungs.
Mm-hmm. Bases are clear.
Okay. And now I'm gonna ask the patient to lie on 180-degree and check palpate the abdomen.
Okay, what would you like to check on the abdomen?
I'm gonna looking for any superficial tenderness, any masses that is palpable.
No masses palpable. Abdomen is soft, non-tender.
Okay. All right. So okay. All right. So Mr. John, thank you for letting me examine today. Do you have
Right.
any concerns for me?
Yeah, doctor, what am I actually having?
Okay. So Mr. John, I've examined you, and yes, it may be related to your heart condition that you've been having this palpitation, and s- so it may be some malfunction in your pacemaker that has been kept. Sometimes there may be some small, I mean, the wire dislodgement of your pacemaker.
Mm,
So that is one of the possibility that I can think of at this moment. However, for this, I'll have to run some test, and I will be able to confirm the diagnosis for you.
all
How
right.
minutes left?
Okay, doctor, it's my pacemaker failing because actually the last check was interrogation was 2 months ago, and the cardiologist told me that it was perfectly normal.
Yeah. Yes, Mr. John. So maybe last 2 months ago it was fine, but you've been having this symptoms since last 6 weeks. So I believe in between this time there may be some malfunction in the pacemaker.
Okay.
Mm.
Doctor, could this be due to my family problem of thyroid? Because my late grandfather had thyroid cancer.
Okay. Yeah, John, I appreciate your question and understanding regarding this. But I've examined you. I think the chances of the symptoms being labeled to the thyroid is very less likely, because I do not find any positive history of thyroid in your in your medical history.
Hmm.
However, yes, I would like to run some blood tests regarding the thyroid gland, and as well to look to rule out if there is any underlying thyroid problem as well. Okay.
All right. Yeah. Okay. Thanks a lot, doctor. But yeah, I'm just feel worried because recently there have been so much thing going on. My partner actually broke up with me because of my physical appearance. So I'm actually feeling quite sad as well. So this palpitation is added extra problem for me now. So I'm actually feeling quite stressed.
Mr. John, I'm really sorry that you had a broken up with your partner, but
Yeah.
I'll try my best to help you.
All right. So
Okay.
do you think I will need an admission?
So at this time, maybe I don't think that
It
you
means
will need admission. Yeah.
All right. So okay, question time.
Yeah.
So Mr. Abhi, Dr. Abhi, may I know what is your diagnosis?
For this patient, I believe there may be some uh, malfunction with his underlying pacemaker for the sixth sinus syndrome.
All
So
right.
that is my first diagnosis, and my other diagnosis is hyperthyroidism,
All right.
and it may be patient's um, episode of anxiety.
Mm-hmm. Okay.
Uh,
How would you
yeah.
like to investigate this patient?
For investigation, I will investigate. I will do a EKG to look
Okay.
for any underlying heart rhythm, if there is any active evidence of sinus syndrome, uh, or any rhythm abnormalities in this patient. And I would also like to perform a echocardiography for this patient,
Mm-hmm.
and I will also like to do a tilt table studies
For.
for any autonomic dysfunction in this patient.
Okay.
And I will also perform a thyroid function test, baseline blood investigation like complete blood count, renal liver function test, and I will also like to perform serum calcium, magnesium level in this patient, and I would like to look for any possibility of pheochromocytoma in this patient by doing the abdominal scans.
Okay.
Yeah.
How will you manage this gentleman?
So I believe it should involve a multidisciplinary team in which I will refer this patient to a cardiologist as well, to look for if there is any chances of lead misplacement in this case, in the and I will also mm, put the patient in the halters
Mm-hmm.
for any rhythm abnormalities, and mm, what else?
All right.
Yeah,
Doctor, may I ask? Just now you mentioned that you are trying to look hard for the scar for the pacemaker, but you couldn't find any. So what could
yeah,
be the possibility? But the
yeah,
patient did mention to you that he had a pacemaker implantation, and he is quite certain.
yeah. So yeah, I'm not quite sure about that because there was no any scar. Normally, the pacemaker are placed under the clavicle, right?
Yeah, usually it'll be infraclavicular. Okay, never
Yeah,
mind. We shall discuss this later.
yeah,
So, what else would you like to offer this gentleman as he told you that he actually feels stress at the end of the
yeah.
conversation? Yeah.
I can also offer
Mm,
psychosocial support for this patient,
mm,
and maybe referral to the psychiatrist
mm-hmm.
for this patient. And yeah, what else?
Okay. All right. So, if you were given more time to ask question, what would you like to ask the patient further?
Yeah, I would like to ask patient's mood.
Okay.
Mm,
Some more?
yeah, his social history, like uh, how he has been coping things,
Mm-hmm. Some more?
and any panic episodes, any thoughts of suicide.
Okay. All
Yeah,
right. So, all right. I think our time probably is finishing soon.
yeah,
Still got 30 seconds actually.
30 seconds. All right. So, okay. So, if at all this pacemaker is failing, what will be your treatment?
yeah. If the pacemaker is failing, then replacement of the pacemaker.
Okay. All right. Then, I think, yeah, I think there are the question that I would like to ask. Okay. So, okay, Miss Dr. FP, how do you feel about your performance?
I think it's okay, but I could not find where is the pacemaker.
All right. Okay. So let's see. So okay. So there are several things that actually you actually miss out in this case. So you didn't ask me about caffeine intake. That's number one.
Caffeine, yeah,
It's
yeah,
very, very important in all palpitation. So
yeah.
it's very, very, very important. So if you would have asked me, then I was actually have the answer of taking caffeine drinks 1 to 2 times per day lah. And it's
Okay.
actually a habit. And did you actually ask about over-the-counter medication or something that from online or friends?
I didn't ask specifically, but any medication that patient was
Yeah.
taking, recreational, anything.
Okay. So basically, the patient is because in the end, actually, I'm trying to help you by telling you that I feel sad that recently broke up with the partner because of
Yeah.
the physical appearance or so. And I did mention that trying to lose weight intentionally. So actually, I'm actually taking some medication called phentermine. If you heard before, it's actually a slimming pills for the
Swimming
past
pool.
two months. Yeah.
Okay.
Okay. And in the end, also family history part of the thyroid disease is a bit. If I didn't offer the diagnosis, offer the info, you actually might miss it as well. Okay.
Mm-hmm.
And so for your clinical communication, for this marking, the clinical communication, I think the history part, you did ask in a focused and fluent and professional manner. So I think I would give you but certain things you actually miss out. Those hard sign, I would say important info. For example, the caffeine intake, the family history of any thyroid problem, and additional drugs lah. So I will give you a borderline lah. For physical examination, I feel is okay. You did look hard for the pacemaker scar and also did actually examine the thyroid, which is very important. So this one will be satisfactory. For clinical judgment, because you couldn't elicit the history, which is very important about the additional drug usage. So this will just go to borderline because the diagnosis is and the differential that you offer will be slightly different. The only diagnosis you can give me is actually pacemaker dysfunction and also a hyperthyroidism. So and another two differential that is actually in my list will be drug induced and also caffeine induced. So this will go to borderline. Then for the concern is very good. You address the concern. If given more time, I will advise you to actually explore more on the patient mood, like you mentioned. Physical sign, yeah, it will be satisfactory. Differential, unfortunately, will be borderline as well. And the welfare will be satisfactory lah. So basically, you get 3 borderline from the clinical communication skill, clinical judgment, and also your differential diagnosis, mainly because you couldn't get the important history. Okay, so what is I would like to bring up from here is that okay, for this patient, he has 6 sinus syndrome on pacemaker, and last interrogation was 2 months ago and was told to be normal. This is the positive that you must get. Taking caffeine drinks 1 to 2 times per day, also very important. Family history of thyroid malignancy. Taking slimming pills recommended by a friend called phentermine is very important. I think somehow we need to know a little bit about the over-the-counter medication and also some more popular over-the-counter or supplements that we should know lah. Phentermine is a suppressant of appetite, which is commonly used for obesity patient to lose weight. And in extra doses or in some patient, it can actually, the most common side effect is actually GI and also palpitation. Yeah. Then the negative, very good. You did ask about anemic symptom. You did ask about hyperthyroidism, and you did ask about family history of sudden cardiac death. And then the drug history that I mentioned is phentermine. And the social history is recent breakup with the partner due to the physical appearance. So if you have more time, you will need to explore a little bit on the depression and also mood, because he did mention about depression and mood. One thing I would like you to notice is that whenever we have the history of palpitation, it is very, very important for you to ask about the characteristic of the palpitation. Whenever we get the complaint of palpitation, first you need to ask awareness of heartbeat. Is it fast or slow? Can you tab it out for me? Is it regular? Is it irregular? Because this is very important. Yeah, some patient can palpitation. It's not just means that it's fast beating. Some patient can have awareness of a slow AF. So yeah, that one is very important question that you actually miss out to ask. Then for the examination wise, check for thyroid sign is very good. You did pulses and ppm scar. One thing I would like to bring to everyone attention is that there is something called leadless pacemaker for the past, and it's getting more and more common nowadays. It is a leadless means that there is no battery box, there is no leads, be it single leads or double leads. It's a we call it like angiogram. You transfemoral or transjugular, you just implant it, and it's just a very small device that can be implanted on the right ventricle, and it's a leadless. So you wouldn't know the patient had any operation done unless the patient tell you and you do a chest X-ray or even an ECG, because from the chest X-ray you can look like there'll be a like spider-like structure on the heart. Then you know that is a leadless. Then the most common one that we are using now is called MICRA, MICRA. For your interest, you can go and read it out. Then you did auscultate for some murmur, and the neck, very important, check for any neck swelling. So the diagnosis for this patient is actually drug-induced palpitation. And then the patient did explain to you that the doctor told him that the pacemaker is functioning well. So pacemaker dysfunction probably could be your differential. Hyperthyroidism, for all palpitation cases, it is not just enough to ask about any family history of past medical condition or heart problem. You need to ask about sudden cardiac death. You need to ask about thyroid. You cannot just generally any family history of any health condition. Is too general for palpitation. Yeah, and then caffeine-induced hypertension. This is also very important. So some patient might drinks up to 4 or 5 cups of coffee per day, so it's very important as well. The investigation that you mentioned will be a ECG, a chest X-ray, an interrogation of a pacemaker, full blood count to look for any anemia, renal profile, and also electrolytes, and also importantly thyroid function test. So most important is stop the offending drug, which is phentermine, and the symptoms will actually resolve within days. So, and you can offer for interrogation of the pacemaker again, but usually it wouldn't cause much problem unless the patient recently had any surgery or had visited a place with very strong magnetic field causing the pacemaker maybe to have dysfunction. Then, but MICRA is a very new technology, so it's most of the time is a MRI or even high magnetic field, it will be compatible. So usually it wouldn't cause much problem. Then you can actually advise to stop or reduce the caffeine intake, and also counselor referral and dietitian. For the concern, yes, you answer most of the concern. Is my pacemaker failing? Do I need a replacement? The answer is no, because definitely this is not due to a pacemaker dysfunction. You can know it by doing an ECG. If every spike, after every spike, you have this QRS complex, most likely it's not dysfunction unless there is no QRS following by each spike, then you know that is something wrong with the pacemaker. Will this palpitation be permanent? Yes, if it's continue taking the offending medication, the trigger is still there, then yes, it will be permanent. Am I having a thyroid cancer? You answered it well, because you mentioned that there is no sign and symptom of a thyroid problem, so it's less likely to be thyroid cancer. But you didn't ask about the thyroid cancer family history until the until the patient actually told you. So yeah, generally I think you did okay, but you can do better. Any question?
Okay. Thank you, doctor. No.
Yeah. Afi, I just want to ask you, when you have this scenario prepared outside, what have you written in your differential diagnosis? Palpitation.
Yeah, doctor. I have written. First I wrote AF,
Okay.
hyperthyroidism,
Mhm.
pheochromocytoma, carcinoid syndrome,
Mhm.
and yeah, this kind of thing.
Mm.
Mm,
So you see that your differential diagnosis, there's no drugs
yeah,
induced like
yeah,
palpitation in your differential, right?
yeah. That's
So again, I just want to highlight the fact that actually paces is just like a game, you know. You have to have a good approach and a like a rule of the game to understand it well, so that you won't miss things that you 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 will miss if let's say you didn't thought of that like, before you approach the case. So if I'm going to approach this patient palpitation, a scenario of palpitation, what I will write outside the scenario when I prepare in on the paper itself is I will separate into a few system. First is perhaps uh judging from the duration, usually it's like a short duration, can be like 1 month, 2 months, or can be few weeks or few days, right? So, but the duration to me doesn't matter because I'm going to screen by system. So let's say you're thinking about respiratory system, then perhaps palpitation, tachycardia, right? So I'm
mm-hmm,
thinking more through, can this be some form of pulmonary embolism to begin
mm-hmm,
with? If it's a respiratory related causes, which is kind of like acute and like short duration. Second is actually you mentioned about cardiovascular is something I need to hit hard for because
mm-hmm,
palpitation can a lot of time associate with a lot of issue. It can be due to like what you say, arrhythmia, cardiac arrhythmia, any form of arrhythmia lah. Oh.
mm-hmm.
And if the patient is a younger age group, I'm thinking more through those, whether
Sure.
there's any sudden collapse to suggest any prolonged QTC
Mm-hmm,
syndrome, long QT syndrome, or even like Brugada, all those kind of dysarrhythmia that I'm worried. Let's say this is a younger age group, but let's say this is a middle age group, then perhaps anything is still possible. Can be some structural causes, can be after patient. I need to hit hard whether patient get any underlying heart problem or not. Let's say patient got underlying heart attack in the past, which may affect the right coronary artery, right? So that
mm-hmm,
can also cause a lot of scar, VT, and also arrhythmia as well. So I will hit hard on the cardiac causes. So cardiac basically all those can be ischemic, can be arrhythmic, can be like structural like HOCM, can be heart failure also. And then I will write the third one perhaps is endocrine causes. Endocrine, the most important thing you mentioned already, which is a hyperthyroid, right? You're thinking more to thyroid. Okay. But don't forget that under endocrine, there's also few things that you need to exclude. Second, more common thing is actually the hypoglycemia. Because
yeah.
hypoglycemia can present as palpitation as well. And the
Mm-hmm,
third one perhaps is what you mentioned. The less common one is feel as well as the you can mention carcinoid, but not very common.
mm-hmm,
But something like feel is something that you want to make sure you didn't miss it. And sometimes hyperaldosteronism, like primary hyperaldosteronism, that one is also possible can come up. But usually they will have hypokalemic symptoms, so you may need to screen for that as well. Then perhaps after the endocrine, I'm thinking more to less I would say less in my list, but I will still exclude is the symptomatic anemia. Anemia is something you need to exclude,
yeah.
especially palpitation, like female palpitation. Then you ask actually which patient is anemic. And when you ask further, then perhaps patient is IDA because of prolonged menses. And then you ask further, suddenly what causes the prolonged menses is actually the hypothyroid.
Mm-hmm,
So you can see that things can run here and there, right? So it's that's why it's important to have your own approach. Other than anemia, then perhaps the last two differential I will write on my paper is perhaps the drugs. Like what Yeho mentioned, drugs and drugs and drugs. We must be very, very vigilant about drugs. So the
yeah.
way you ask about drug, I can see that why Yihong didn't offer you the phentermine is actually you ask about any other drugs because certain patient does not consider the medication they buy from anywhere else as a drug. They consider that as a form of supplement. So you see,
Mm-hmm,
when you ask this question, they may not like agree with you that oh I'm not taking any drug. But may ask further, do you buy any any medication or any supplement?
mm-hmm,
For example, like traditional one or anyone recommend to you. If you ask further, then they may give you the answer. So this scenario is difficult because you didn't manage to prod further. If you have prod further, you would get the diagnosis. Okay.
mm-hmm,
And also another thing is the pitfall would perhaps because you didn't mention you didn't write that in your differential diagnosis. Therefore, it's unlikely for you to ask in particular as well. And the remember anything other than drugs is also important about the food, the diet that we take. That also include like for this scenario, caffeine is very important. So if you think on this perspective, you will also ask a bit on the lifestyle and also the mode. And the last one, perhaps the last one that I will write after excluded everything is the anxiety disorder. But it can come out, but I don't think it's like a priority. But something that you, if you are stuck and you really don't have any other positive symptom or sign to suggest, and patient's mood symptom is very significant, then perhaps you can offer that. But that is provided after you excluded everything. So this is generally the approach to palpitation. So you exclude the acute one, which can be cardiac, can be respiratory, then the endocrine, then the hemato, which is anemia, then the drugs and anxiety in summary. Okay?
Yeah.
Okay, all right. Yeah, Yihong,
Yep.
you got
Yep.
anything
So
to add on?
actually, in this case, I try to put multifactorial. So it's just like you need to ask this, then only consider is a complete history. So it's like there is a family history of thyroid, there is taking supplements, there is like taking caffeine, everything. So it's very important for you to exclude all this, also ask all this. So eventually you can actually say that it could be a multifactorial causes of this palpitation. It's not wrong. You can say it could be a multifactorial if you can get all the diagnosis, but the most likely cause is this drug-induced palpitation. Yeah.
Okay.
So,
Okay.
right, if there is no question, then we shall proceed to our second candidate. Second candidate is Dr. Jana.
Hi, doctor. I'm here.
Yeah, all right, Dr. Jana. So, it's a case of long case as well. I will give you 4 minutes to prepare, and after 4 minutes, we shall start the clock. All right. Okay, your 4 minutes starts now.
Okay, 4 minutes up. Before we start, I just want to ask Dr. Jana, where are you from?
I'm from Putrajaya.
Oh, you're from Putrajaya. Okay, okay. All right. Are you ready? You can start.
Okay, doctor. All
Okay,
right.
I will start the timer. Okay.
All right. Okay. So, okay, start.
Okay. Good evening, Mr. Edward, and Madam Katie. I am Dr. Jana. I'm the medical officer who is assigned to attend you today. I get to know from here that your son has not been feeling well recently. Could you tell me more about it?
Yes, doctor. Actually, my son Edward has been having this they call it fitting since yesterday, and there are actually 2 to 3 times fitting since
Okay. All right. Can I ask a bit more further about this? Did you witness this, or did anybody witness this?
Yes, I actually witnessed this fitting episode. So, she was just like normal after finish taking his food. Then subsequently, he has this jerky movement over his hands and also leg. Then subsequently, he actually was. I kept calling him, but he actually didn't respond to my call. Then he just fall down, and subsequently, slowly he can wake up after about 10 minutes. That's the
After
first.
after about 10 minutes. Okay. Did you notice that his eyeballs? Did you notice the eyeballs went up or anything like that?
Before he actually lost responsiveness, yes, I did see his eyeball is actually roll upwards.
Okay. Did you see that any saliva came out of his mouth?
Yeah,
And at the end of the episode, did you notice that did he pass motion or did he pass any urine?
no,
Okay. Was Edward able to recollect what had happened after the episode?
no. He told me he just feel tired, but he
Hmm?
couldn't answer what actually happened to him.
Okay, all right. Is this the first time this has happened? Like you're saying since yesterday, since this was the first time this has happened, or has this been happening for multiple times already?
Actually, this is the first time he developed this jerky movement and also loss of responsiveness.
Okay, all right. So this is the first time. Okay, all right. I'll just want to dwell further on this. Did prior to this, did he have any sort of fever? Did you feel his body was warm to touch, or did he say that he feel that his body was feeling any chills and rigor?
No,
No. Okay. All right. Very good. Did he complain of his neck being very stiff?
no.
Any headache?
He did told me that he did mention that he actually have some headache before the this jerky movement, but it's just lasted for a few seconds and then it resolved on its own.
Okay. But no prior episodes of any headache or anything, huh?
No.
Okay. All right. Okay. Okay. That's good. Okay. And the thing is, I want to ask further. All right. Does Edward have any medical illnesses?
Um, Prior to that, actually, the doctor mentioned that he looked slightly different compared to his peer. But you see, we're actually from rural area before this, so our access to healthcare is not that good. So I actually never brought him to seek any medical attention until yesterday. But
Okay.
yeah, my friends and also the when he was born, some of my friend actually told me that he looks slightly different from his peer.
Okay. Does he have any difficulties in performing in school academically?
Yes, he's actually attending a special school because he actually have this slowness in learning.
Okay. Anybody else? Anybody else in your family who also has any issues with difficulty in who also attending the special school?
No, his brother is actually normal.
Okay, all right. Okay, okay, that's good. The thing is, does he have any heart problems or anything like that?
What do you mean by heart problem, doctor?
Does since from birth till now, has he been admitted to the hospital or has any examination by any doctor said that he has any heart problems?
No.
No, okay, all right, okay. And did you notice anything in like in his skin? Is it like very easy for him to develop like any acne around the face like that?
Yeah, is he actually have all this? I would say, rashes. And lesion for
Okay,
quite some time, and it just persistently there.
I see, I see. Did you seek any treatment for this?
No, like mentioned, personally, we stay in quite rural area, so it's kind of like difficult for us to bring him to the hospital.
Okay, all right, okay, okay. And then, okay, I would like to ask further, has your son done any operations or anything prior to this?
No, no operation done before.
Okay, all right. Do you know of any of your family members from your husband's side or from your side, anybody with any history of them having seizures like what Edward had to go through?
No,
No, okay, all right. Is Edward a smoker?
no, he
No.
never smoked.
Okay, all right. Does he consume any alcohol?
No,
Okay. That's one thing. Okay. Another thing I'll do like to ask, have you noticed whether Edward has been taking any illicit drugs like cocaine or amphetamine or anything like that? Have you caught him taking any of these medicines before, anything like that?
no, because he tends to stay with his friend who are actually in a special school as well. So
Okay.
I personally, I never witnessed any misconduct so far.
Okay, all right, okay. And also, I'll just want to ask further regarding this one about his fitting. Did he have any sort of any diarrhea or any vomiting prior to having these episodes of fitting?
No,
Okay, all right, okay, that's very good. Okay, may I proceed to examine the patient?
all right, okay, can.
Okay, I would like to assess the patient's GCS. Is the patient orientated to time, place, and person?
He's orientated to time, place, and person, but he is slow in response.
Okay, all right. I would like to perform a cranial nerve examination. Is there any cranial nerve deficit?
Which nerve?
I would like to start with the second cranial nerve.
Okay.
So, is there any issues with his visual acuity? Is there any issues with his visual field? Does he have any issues with his accommodation?
Okay, visual acuity is 6/9 on both eye. Then visual field is normal.
Right.
Accommodation is normal.
Okay. All right. Okay. And his pupillary reflexes, is there any RAPD?
No,
Okay. All right. And then I would like to check 3, 4, 6 simultaneously. Any evidence of any ophthalmoplegia?
no evidence of ophthalmoplegia.
Okay. At the same time, since I'm checking the eye, is there any evidence of vertical or horizontal nystagmus?
No nystagmus.
Okay, very good. And then I would like to proceed with cranial nerve 5. Any loss of sensation over the face region?
Fifth cranial nerve is normal.
Okay, all right. And then subsequently, I'd like to proceed with the 7th cranial nerve. Is he able to wrinkle his forehead?
Yes.
Okay. Is he able to close his eyes and is it able to resist my movement when I try to open his eyes?
Yes.
Okay. And do is there any like on examination? Is there any facial deviation? Anything?
No facial deviation.
Okay, all right. And then I'd like to check cranial nerve 8. Is there any loss of hearing?
How would you like to check for cranial nerve 8?
I would first like to use the tuning fork and then see whether there's any conductive or conductive hearing deficit.
No, it's normal.
Okay, all right, okay. And then I would like to check for what do you call it, for his gag reflex. Is there any uvular deviation?
No uvular deviation.
Okay.
You can
yes.
you realize that actually there is the uvula looks slightly weird. It's a bifid uvula.
Okay. All right. Okay. The other thing is that what do you call it? Is he able? Is there any weakness when I ask him to move his neck or over his sternocleidomastoid muscles at both sides?
Yes, it's normal.
Okay.
The power is full.
All right. Is he able to shrug his shoulder?
Yes.
Okay. And when I ask him to protrude his tongue, is there any tongue deviation?
Tongue is central.
Tongue is central. And is there any weakness of the tongue muscles when I ask him to push towards the cheek?
No, it's normal.
Okay. All right. Very good. And then looking at the picture, there is I can see the image there. Is okay. So that is throughout the face, is it?
The face is more like a butterfly distribution.
Okay. All right. Okay. And then I would like to check his back. I do see from the image there is multiple what do you call it? I don't know how to tell it like without using the scientific name, doctor.
You can use the scientific name, no problem.
Okay, you can use the scientific name.
Yeah.
What do you call it? This one is the. Is this the chagrin patch?
Which one? On the top or on the bottom?
Could you on the top? On the top. The bottom one looks like, yeah. And then down looks like a cafe outlet spot. The one on the left side looks like cafe outlet over yeah.
Okay.
Then over the top, if I'm not mistaken, that's a chagrin patch.
Okay, chagrin patch. All right. What else?
Okay, and then also I'd like to check his cerebella. Is there any difficulty in finger nose testing?
It's normal.
All right. Is there any dysdiadokinesia?
No.
Is there any staccato speech?
No.
Okay. Is there? I would like to assess his gait.
Okay. Gait is normal. Normal arm swing.
Okay. All right. And also I'd like to just see his Romberg's test. Is the Romberg's positive?
Romberg is negative.
2 minutes left.
Okay. All right. Okay. Madam Katie, is there anything which is concerning you?
Doctor, yeah, what happened to my son?
Okay. All right. Okay. I will have to, I mean, from my examination and from the history which I've obtained from you, it is quite likely that your son has a certain disease which we call as tuberous sclerosis.
What is that, doctor?
Okay, all right. This tuberous sclerosis is a type of disease whereby it's a genetic disease. It's a genetic disease, and it tends to cause you to develop certain tumors around the body, and it tends to also affect your skin, and whereby it's very easy for you to develop what you call it, like the lesions which your son is having around the face and also on his back. It also has a high risk of developing his seizures, And also another thing which we realize in patients with tuberous sclerosis, also they would tend to have difficulties in his studies as well.
Oh, is it something that runs in the family? You mentioned just now is genetic.
Yeah, yes, it is. It is something which runs in the family. That's why what you call it? It runs in the family, and how to say? But we'll definitely have to screen your other family members to make sure that whether anybody in your family members also are having this as well.
Oh, I see. It sounds very serious. Can this
Time's up.
condition? All right. Okay. Question time. Okay. Diagnosis.
Patient has epilepsy secondary to tuberous sclerosis. My differential for this patient is young, whether it could be an infection, but then patient doesn't exhibit any signs of infection. Other thing is whether patient is taking any illicit drugs or withdrawal to any illicit drugs. Other differentials of seizures, could it be secondary to any electrolyte imbalance? However, patient doesn't have any signs to indicate the patient having any gastrointestinal losses.
Okay. Can you tell me some association with tuberous sclerosis?
Associations with tuberous sclerosis, the patient sometimes can present with what do you call this one? CP angle tumors.
Okay.
Other the things associated with tuberous sclerosis, this patient can present with epilepsy, adenoma sebaceum, and low intelligence.
Some more?
Some more. Any behavioral problems?
Behavioral problem. All right. Okay. So how would you like to investigate this gentleman?
I would like to. I'll definitely like to do genetic studies, but I be honest, boss. I cannot remember exactly what gene is where the mutation is occurring in it.
All right.
And then definitely for in view of his epilepsy, definitely I would like to investigate by doing a CT and an MRI brain to rule out any space occupying lesion.
Mm-hmm.
To take bloods and inflammatory markers to rule out any signs of infection, and also to take electrolytes to rule out any hyponatremia or hypocalcemia, which could also lead to him having his seizures as well.
Okay, so you mentioned it's tuberous sclerosis. How do you manage this gentleman?
Management of it should be in a multidisciplinary approach. At first, patient education towards both the patient and the family, counseling regarding the condition whereby patient will have these issues. Regarding his epilepsy, management of the epilepsy will be with anti-epileptics. And then regarding his skin condition, management of the edema sebation with emollients, and also referral to the dermatology team for further control of it. If regarding his regarding his education, definitely referral to a counselor, and also if let's say patient has any signs of depression, referral to the psychiatric team for treatment of that as well.
Okay, so for his seizure, any specific anti-seizure medication that is useful that you are aware of?
I'm not sure, but I think, is it sodium valproate is the first line? I'm not exactly sure, boss.
Okay. And just now you mentioned about emollient for the skin lesion. What else can you offer if
if
doesn't work?
If let's say it is what do you call it for adenoma sebation, can we give him like the things like the what do you call it, the ketoconazole shampoo or
That one is for seborrheic dermatitis.
Okay.
All right. Okay. Now mind. Any immunosuppressant that you actually know of that can help with this condition?
No, boss. No, I'm not. I'm not sure of. I'm not sure of that.
Okay. So just now you mentioned about family. It runs in the family. Can you tell me what mode of inheritance is tuberous sclerosis complex?
I am thinking it's autosomal dominant.
Okay.
Yeah.
And is it all autosomal dominant?
Or that I'm not sure, boss.
Okay. Any
That I'm-
specific diagnostic criteria you actually aware of?
Diagnostic criteria. It, I no, boss. No, I'm sorry. I'm not sure if like if
ISL?
like for no, I do not know.
All right. It's all right. Okay. So, okay, Dr. Jana, how do you feel?
I mean, getting the diagnosis was okay. I don't because I feel the features wise was quite straightforward, and then the epilepsy because I remember tuberous sclerosis that what do you call it? There's the pneumonic epiloia, the epilepsy, the low intelligence, and the adenomous sebaceum. So that was the pictures really did help in terms of finding out what is the cause of it. In terms of differential, I couldn't find. I couldn't from his history and examination. I couldn't find any other things which could be like a very good differential towards it, other than the ones which I said just now. Management wise, I do feel I do need to know much more about the management of tuberous sclerosis.
All right. Okay. So yeah. Okay. So some feedback about your performance. So basically, this is it's a case of either you know or you really don't know. Okay, because it's a spot diagnosis. When you go in, outside is recurrent fitting, but when you go in, if you see the features, you will know spot diagnosis. This is tuberous sclerosis. Just like from outside, if the condition is recurrent headache, high BP, you go in, you see an acromegaly patient, so you know the diagnosis. So now the question is, you need to elicit all the supporting features to support your diagnosis. Tuberous sclerosis is associated with a lot of things, and you need to ask all these things within this session, and you need to examine all of them. Try to
Okay.
make it and simple. That's why it is not wrong. Your approach for fitting is good. You did ask about the semiology. You did ask about any trigger. I know you tried to rule out meningitis. You asked about family history. It's good. And you did ask a little bit association about tuberous sclerosis, which is learning difficulty, low IQ, and you did ask about the cardiac. And fitting, yes, you did ask, and you try to rule out some brain tumor as well, because you did ask a little bit about headache, everything. So it's good, but you miss out quite some chunk of the association with tuberous sclerosis, which is very important. And you spend quite some time on doing the full cranial nerve examination, which is actually not really required if you have a spot diagnosis of this tuberous sclerosis. Your main aim is to provide as much positive physical sign or physical finding. Try to look much physical finding that is associated with this symptom, this syndrome, which I will explain in the next slide. Okay, so unfortunately for your performance, you are good with the fitting, but I think you spend too much time in examination, which is because you didn't ask much about the association and also the possible complication of tuberous sclerosis, and it's very important. So for your clinical communication skill, I would actually thinking of giving borderline or unsatisfactory because you miss out a lot of history from for the tuberous sclerosis. Then for the physical examination too, you actually didn't examine the thing that I would want you to examine, which include the cardio, respi, and the abdomen. Later, I'll explain to you why it is important. So I will mark you unsatisfactory for that. Clinical judgment, appropriate investigation, because you didn't have elicit much about the association. Again, you couldn't offer a proper investigation and also treatment for this gentleman. Emollient for the adenoma sebaceum won't work. emollient is for all those dry skin, or it won't work on this adenoma sedation one. So again, your clinical judgment, I will also need to give you unsatisfactory. Concern wise, yes, I can give you full mark because you address the concern well. But just bear in mind, because this gentleman, the way you asking illicit drugs is a bit how should I say, is a bit too direct, because this patient is, you know, he cannot give a very good history, so you are talking to a surrogate. So it might sound a bit rude to the patient mother that did you witness your child actually using an illicit drug? So it might sound a little bit rude to them for asking this question. In more educated patient, they might actually feel offended. Okay, so but generally your concern is okay. I can give you satisfactory. Physical sign, again, you didn't elicit much physical sign. I will actually show you the skin lesion, and I will explain to you which one is what actually, because it's a very good patient. It's a real patient that happened to be in my hospital. So I actually managed to capture the picture, and with his consent to get to share with you all. Then, so your identifying physical sign will be unsatisfactory as well. Differential diagnosis for the latest format, because it's a very clear-cut diagnosis. So sometimes the examiner might actually not ask you about the differential diagnosis. Once you can get the diagnosis, then usually the differential diagnosis part, they can give you full mark lah. So it can be satisfactory. Welfare, I will give you full mark lah. So basically, you couldn't elicit much of the association. So like you mentioned, there is a pneumonic, but for tuberous sclerosis, you must know the important association. So for positive history, you must get recurrent fitting. This is first time, but already 3 times in 2 days. Learning difficulty, rashes over the face, headache prior to the fitting. These are all very important to us. SOB, why? Because tuberous sclerosis can associate with lung condition called lymphangial leiomyomatosis, or it can actually have pneumothorax or even lung cyst, pneumothorax secondary to ruptured lung cyst. So it's important to ask about SOB. Chest pain. Chest pain can have cardiac rhabdomyoma in tuberous sclerosis, because like you mentioned, it's an abnormal growth in every part of the organ. So it can happen in every single organ. Hematuria, this is very important. Hematuria, if patient have renal cyst, if they have one of the differential diagnoses for bilateral palatable kidney is actually tuberous sclerosis complex because of renal angiomyolipoma. So you need to ask about hematuria or difficulty in passing urine. Then,
Doctor, sorry, regarding the cardio, what was the thing again the patient has?
cardiac rhabdomyoma.
Okay.
Yeah. Then you need to ask about abdominal pain and bowel habit, because again, they can have abnormal growth, which is hematoma. They can have polyposis of the stomach. They can have polyposis of the large intestine. So they can have hematochezia. They can have crampy abdominal pain or auto bowel habit. So it's very, very important, because it's basically affect almost all systems. So if you really ask me about the systemic review, I can tell you no, then I know you that trying to rule out the association and the possible complication. Then you have to ask me also, had history of febrile fit during child. I think you asked me about this, so it's good because they can have febrile fit, they can have infantile spasm during young age or infant period, which is very common. Then social history, you ask about special school, okay, good. No family history of similar complaint. So for the sign, you need to know also, for tuberous sclerosis is like a ticket for you. You go in, you see this is tuberous sclerosis. You are trying to tell the examiner, I know every single sign that this patient has. So adenoma sebation, which is the butterfly distribution in the nasolabial fold, is the patient is actually having. This one is adenoma sebation, all this. Then angiofibroma is mainly on the eyelid. It's just an abnormal growth on the eyelid. Gingiva hematoma is you need to look at the gum. So you need to ask the patient to have a look on the gum whether there is abnormal swelling or not. Okay. Next will be all the skin lesion. Sanguine patch. This is the sanguine patch. It's actually a cobblestone appearance. If you palpate it, you can palpate an uneven surface. It's a cobblestone appearance. The bottom here is the Shangreen patch. Next will be your skin tag, or another more fancy name is the molluscum lah. Molluscum fibrosum pendulum, usually found on the axilla, usually found around the neck, nape of the neck. Then your cafe au lait spot is actually all this small one. Cafe au lait is this one is cafe au lait. Okay. Then next will be your ash leaf macule. Usually ash leaf macule or ash leaf patches, the examiner will prefer you to say is a wood lamp examination, means you need to use a special device to say is a ash leaf patches. The other term more is easier for you is actually called hypomelanocytic patch, which is all this white one is called hypomelanocytic patch. It's the skin, then you can skin finding that you can find. Some more from the news, you can find some. You may find some periangle fibroma, which is also abnormal growth near the nail, close to the nail beds there. Okay, so these are all the skin lesion that you must know when you are trying to describe a tuberous sclerosis skin. Okay, next, fundoscopy. You examine everything, but you didn't offer fundoscopy, and also you didn't mention about leash nodule. You can Google what is leash nodule. It's basically on the iris. There is a nodule there, so it's a leash nodule. You need to tell there is no obvious leash nodule. And if I'm given a fundoscope, I would like to perform a fundoscopy to look for any retinal hematoma. Then CVS is the murmur. If it's they have the cardiac rhabdomyoma, they might have a heart failure, so they might have dilated cardiomyopathy.
Dr. Lee, one question. So that means the leash nodules, you can see it both in neurofibromatosis and also in tuberous sclerosis, is it?
Yes.
Okay.
Yeah. Then lungs, need to auscultate the lung for fine crepitation, especially in lymphangial leiomyomatosis. You must offer to do auscultation. If you don't do full one, probably I will just auscultate the patient. Okay. Abdomen, this one is very important. Ballotable kidney must really ballot, go and ballot, palpate and ballot, and see whether there is any ballotable kidney or not. Most, I think quite a number of tuberous sclerosis complex patients have a ballotable kidney one. Either one side or both side, but usually both side lah, because it's all the cysts, and also it could be this angiomyolipoma. And if a scenario come in like patient have underlying tuberous sclerosis complex, come in with severe abdominal pain, your differential must be rupture cyst, must be a bleeding hematoma or angiomyolipoma. That's the story lah. Then for the investigation wise, like you mentioned, basic blood count, a chest X-ray to look for any lung cyst or pneumothorax, or even lymphangial leiomyomatosis, probably an X-ray plus a CT thorax lah. Then ECG echo, good. MRI to look for any brain lesion. Okay, for the brain, refractory seizure can be due to a few things. It could be due to some tuber, cortical tuber, which is the growth in the brain. It can be due to hydrocephalus because of structural obstruction, or it can be due to a condition called SEGA. Have you ever heard of SEGA in tuberous sclerosis? No? Yes, no? Okay. SEGA basically means subependymal giant cell astrocytoma. Is basically a growth, a small specific growth in the brain. And there is a specific treatment for this SEGA. So you need to know also. Then you need to do an ultrasound, KUP and UFAM to look for any hematuria and also the renal problem. So it's a very, very, very systemic disease. So you must know. Then for the management, you mentioned MDT, good. Genetic screening, who to screen? First degree relative. Usually it's the first degree relative and the siblings. Then ophthalmo referral for the retinal hematoma and phacoma. Then neurologist referral, and specific anti-seizure medication need to be avoided. There are actually some anti-seizure medication that is very good for this tuberous sclerosis fitting, but some need to be avoided, especially carbamazepine and phenytoin, because they can actually trigger the spasm. Then just now I did ask you, what do you come across with any immunosuppressant that you know for this specific condition? In a patient with SEGA or renal angiomyolipoma or even lymphangial leiomyomatosis, the treatment option is actually sirolimus or everolimus. This actually proven to actually improve the condition and also reduce the risk of transforming into a malignancy. And for the dermatological referral, it is not emollient, it's actually laser ablation therapy or surgical resection of the adenoma sedation if it's really troubling you, the patient. So the concern, you address it. What happened to my son? You explain it as a recurrent seizure secondary to this tuberous sclerosis complex. Is this inheritable? Yes, it's autosomal dominant, but bear in mind, more than 50% is actually spontaneous mutation. So it might not have a family genetically run in the family. Can it be cured completely? Okay, this is as you know, it's a genetic problem, so it cannot be cured completely, but you can control the complications, slow down the progression. So you need to have some basic knowledge about this disease before you can tackle this condition. And one thing I quite like about this condition is that it is straightforward, and if you memorize the diagnostic criteria, then you will know what to ask, because in the TSC 2012, I think, that 2012 diagnostic criteria, there's either more than 2 out of 11 major or 1 major plus more than 2 or 3 out of 6 minor. If you can memorize the major one, then you know what to ask and you know what to examine in the physical examination already. Then you won't be lost already. So this scenario is basically to tell you from outside it's recurrent fitting, but when you go in, you know it's the diagnosis as a spot diagnosis. Then you need to deviate a bit. Don't just go all about the fitting. You need to ask about association. You need to ask about complication already, because examiner wants to know whether you know this condition well or not. Yeah. Any question?
No, doctor, but do you have a picture of this one, doctor, that criteria, the diagnostic criteria thing? What's the name of that?
It's a tuberous sclerosis complex 2012 criteria. If I'm not mistaken, it's 2012. You just type in Google TSC 2012. It will come up. Major got 11, minor got 6.
Okay. All right.
Everything
Dr.
you...
Jana. Yeah, right. Yeah, never mind. Continue.
Everything you in the diagnostic criteria is actually already systemic based one. They got renal, cardiac, they got respi, they got all the skin lesion there already. One, it's listed out nicely, just like the neurofibromatosis criteria.
Okay, all right.
Yeah, Dr. Jana, I got one question for you, or perhaps 2 questions. First question is, are you getting any seats for the exam this year?
Yes, doctor.
In March, right?
Yes, doctor.
I see. Okay. So are you be practicing?
Yeah, but based on today's class, there is still a long way to go.
Because what I can hear from your practice is that I feel you need more practice. You can see that it is not surprise to me that when you, I know you're trying your best. Definitely your effort is well shown, but the way in answer question, I can see that you are not ready at the moment. But I would say that definitely in 2 months time you will be a lot better than now, because sometimes I need to tell directly, because that's how you will get a drastic improvement. What I can see from your performance is that is this the first time you encounter a tuberous sclerosis station?
Yeah.
So are you like shocked when you saw the photo?
The photo part, when I saw the skin lesions, I managed to get that, but then I really didn't know about the what do you call it, the other associations which you must know. That is the part which I should have learned up about.
I can see that because we can hear your tone that you are becoming a bit nervous, and therefore a lot of things that you try not to do will eventually do subconsciously. That includes using a lot of medical jargons. So you see, because this is like we need to adjust our tone and also language based on the patient or surrogate education level. So this is you're talking to the mother who is very, she keep on repeating that she is actually from very rural area. So therefore your your words of choice should be also a bit more appropriate in that setting. You cannot say that, are you taking any illicit drugs like amphetamine, like cocaine? You know, you mentioned all the things that is not nice to hear as examiner point of view. I would suggest that instead of saying all those jargon, you can mention that do you happen to your child to notice that it takes any party drugs or any illegal drugs? That would be fine, you know. I know that you are trying your best not to miss out any single possibility of drugs that can cause seizure. But having said that, back to this context, back to this setting, I think it would be suffice if you just ask a very simple question instead of giving like so precise question. And second thing is, some examiner, they don't like to hear the word diarrhea. They don't like to hear some the medical term that we like to use. So I would advise that sometimes you realize that if you listen to my previous session, I always try to mention something like, you know, do you have any loose motion, or do you pass out any loose stool? I don't like the classic English like, do you have any back passage issue? I don't like the term like back passage, or you know, pass urine is like water passage or something like that lah. But I don't like to use that because to me it feels unnatural. What we like to ask patients is, do you have any issue in passing motion? Do you have any issue in passing urine? I mean, just a very simple English also. But for your case, it's a bit different because you are, when you're nervous, you tend to use a bit more jargon. And second thing I realized is that for this scenario, what I can see that you know that you are dealing with a tuberous sclerosis complex, but what you did not able to elicit is that you want to show to the examiner that this is a PSC. So therefore, you didn't ask enough question and examine patient enough. If I see back your timer, because I'm a timekeeper somehow, so if I see your timing, you actually use about 7 minutes for history taking. That's very short. That's really short. So sometimes when we practice a lot, right, you realize that if you use history taking, you only use like less than 7 minutes or even 7 minutes, it means that your history is not enough. Because a good history for any scenario should able to give you a good 8 to 9 minutes in order for you to get enough history, you see. So that's also another clue that when you finish a thing scenario, like it happened to me as well when I first prepared, right? I got a very classic station of like cluster headache. I'm very sure that this is a cluster headache. When I got a scenario of headache, I asked or say, fulfill all criteria, I'm very sure already. And therefore I asked all the question very fast, but I didn't manage to screen through all the differential scenario like entirely. Because cluster headache, one of the differential diagnosis can also be some form of sinusitis, you know. Sinusitis can also present with eye symptom, you know, rhinorrhea, all those kind of, you know, runny nose, red eyes. So all these things is also one very important for us to include in differential diagnosis, in which I didn't that time. So I was being reprimanded because I was very, you know, once you're sure of diagnosis, you just go to that direction and then you just everything you miss a lot of things, and therefore the history taking is not adequate. For your case, you spend a bit of, I would say, actually your examination time is considered excessive. And if you really do all those cranial nerve, definitely by the time of 2 to 3 minutes, you will be stuck in a cranial nerve alone. The reason why this examination find a bit smooth for you because it is like a virtual thing, so you ask and then you get the answer straight. But in real life, when you examine the patient, ask patient to look up, look down, look side, and then you shine the torchlight to check for the pupil size, everything, it's all going to spend some time. It's not wrong to actually check for cerebellar sign for this case, but actually it's not common. You know that the neurofibromatosis type 2 is the one that associated with CP angle tumor. TSC is less association with this cerebellar lesion. But having said that, all the tuber, what we call as a cortical tuber can actually occur in anywhere. It's just that this is not the main point you want to elicit. You want to elicit what is the main issue. Though usually for the tuberous sclerosis complex, you can go by major or minor criteria, but I found it a bit difficult for me to digest. Some actually okay, like Yihong, I think he's very well versed with the diagnostic criteria. For me, I'm a bit simple person, so I like to, because it's a neurostigmata syndrome, right? Got neural manifestation and also the cutaneous kind of stigmata, right? So I will elicit all the skin lesion that's supposed to suggest this condition. So I will look hard for this adenoma subbacum, which is the fibroangioma of the face, also the eyelids, and then asking patient to open the mouth, check for any tongue issue, any lips issue. And then I will also go to the whole face, I will ask patient to actually gently and courteously try to undress a bit, expose a bit at different time. See for the hand. Remember, this kind of patient, you need to check for the trunk, front and the back. Because if you just see the hand, the legs, you will miss all those cafe au lait spot, and also the hypomelanic patch, because they only found in certain locations. Sometimes it's not all location will have it. And definitely the sanguine patch is the one I immediately want to look at the back, at the sacrum region, to look for all this cobblestone appearance. And then all those the remaining thing perhaps is not that important, like skin tag. To me, it's not very important, but something if you found it, you can remember, you can mention. And also don't forget to check the nails to look for this periangle fibroma. So I know that the cutaneous part I've done. So you want to check the neural one, right? You can check for, yes, you can check for increased ICP, right? You can check for 3, 4, 6, no problem. If you want to check for the pupil reflex, it's also not an issue, because want to look out as so-called 6 nerve palsy, like pupil dilatation, right? But you also want to also mention that there's no like partial ptosis or any ptosis you can see just by inspecting to save your time. You want to check for cerebral sign, not wrong. If you have time, you can check. But this patient, I will really try to, like what Yiho mentioned, to auscultate a bit on the lungs and also the heart, and then quickly examine the patient abdomen, asking patient to lie down flat, because I want to look for any bilateral kidney to show that you are actually looking hard for any renal angiolipoma or even renal cell carcinoma. And bedside at that point of time, I will also mention to the examiner that to end my examination, I will check for I will do a fundoscopy to check for retinal lesion like hematoma. I will also order a bedside urine dip to look for any hematuria. Okay, and then after that only I will sit down properly and will talk to the patient. So if you do all these things properly, right, actually 3 to 4 minutes is just enough. Okay, and if you do it like professionally, definitely you have enough time. You don't have to go like neuro system very detailed. You just need to elicit the important points, like what Yiho mentioned. Okay, so I can see that you are fluent. The good thing about you is you are very fluent. You get history very fast, and your speech also very fast. So, but what I can think of is actually you can do a lot better if you have your own approach, and if you know the exam style. Once you know the exam style, what are the things that you're expected from this kind of scenario, definitely you will score very well. I tell you, tuberous sclerosis complex can come out as a station of hematuria. Okay, it can come out as a station of hematuria, and when you examine the patient, you found a bilateral kidney, whether it's a unilateral or bilateral kidney. This can be like a real station. It's a very kind of like hot scenario that we need to know. Another thing is like neurofibromatosis lah. HHT, like hereditary telangiectasia, hemorrhagic telangiectasia, is quite rare. It's only mainly in overseas. But if they really manage to find this kind of patient, then something that we need to know a bit. Okay, but like neurofibromatosis and tuberous sclerosis complex is something very common. You can see you can find one in the district hospital. Definitely, it's not rare. I can also find a few in HKL previously. Okay, so my question to Dr. Jana is, you know that the seizure, like what Dr. Yiho mentioned, right? Seizure, when you mention about seizure in tuberous sclerosis complex, right, you're no longer mentioning the differential diagnosis like drugs, hypoglycemia, or any other precipitating factors alone, but you are actually looking hard for any possible cause in association with TSC. So for this, you can mention that differential diagnosis to explain the seizure can be cortical tuber. Okay, it can be SEGA, ependymal giant cell astrocytoma. It can be some form of any form of angiolipoma in the brain as well. And it can also, sometimes when the SEGA is very huge, it can actually cause obstructive hydrocephalus. So all these are the possible differential diagnosis in relation to the seizure. Okay, so I will going to post a photo of the what is SEGA later on in the group later, but we shall proceed. Okay, I think don't want to drag too long. Thank you so much. I hope Dr. Jana will learn something. The key idea for you is you need to practice. You really need to practice more. From your discussion, it seems that you are still have some space of improvement, but I'm very sure that after tonight, with more practice, you will be a lot better than this. Trust me. Okay, all the best.
Okay, thanks, Junmin. Thank you, Lee. Also, thanks so much.
Okay. All right. So we go to the next case. Next case supposed to be Dr. Aaron. Is Dr. Aaron around?
Yes, doctor. I'm here.
Yep. So, okay, Dr. Aaron, you will be given 4 minutes to prepare. Then we shall start your 4 minutes now.
Okay.
Okay, 4 minutes up. You can
Okay.
start.
Start.
Hi, good morning. My name is Dr. Aaron. Can I confirm that I'm speaking to Madam Wong, 70 years of age?
Yeah, I'm Madam Wong here.
Hi, nice to meet you. I'm the doctor in charge of the acute medical unit today, and I've been reading that you have some health concerns. Can you tell me more about it?
Yeah, doctor. Actually, I have been having this painful skin rashes for the past 3 weeks, and it's actually worsening, and I'm actually having more frequent pain that actually caused me couldn't sleep at night.
I see that must be very troubling to you. I hope
Yeah,
that by the end of this consultation, we are able to help you. So can I know that where did the painful lesion start? Is it
Okay. Let me show you my my leg first. Okay. So
Nice.
actually, the lesion actually started on my trunk, then subsequently actually goes to the my arms, my hands, and then subsequently to my legs. And
I
everything
see.
happened rather fast, about 2 days. Then my whole body is covered with all the rashes and the skin lesion.
Okay. Is it itchy?
It's not itchy.
Does it have any discharge or any secretions out from the lesions?
Oh yeah, sometimes it actually have some yellowish discharge, but there is no bad smell about the discharges.
All right. And do you have any fevers?
Oh no, I have no fevers.
Okay. And do you notice any sores in your mouth?
No sores in my mouth as well.
Do you notice any red eyes or itchy eyes?
No, no red eye, no itchy eyes.
Okay. All right. Do you find that anything actually helps with the pain or makes the pain worse?
Actually, I took regular Panadol. Initially, it helped, but now when the pain is actually getting more frequent, I find it is less helpful nowadays for the past few days.
Okay. All right.
Mm.
Just a few other questions. Do you notice any other joint pains?
Uh, I do have some knee pain, but it was way back like few years ago, and the doctor told me that it was due to my osteoarthritis.
Okay, and has the knee pain gotten worse during these 3 weeks?
Oh no, the skin
Okay,
lesion is the one that actually make me more uncomfortable and painful.
I see. And do you have any excessive hair loss when you wake up in the morning?
No,
And uh, do you have any loss of weight?
no, I do not have any weight loss.
Do you have any cough?
No cough.
Okay. Do you notice any lumps and bumps in any parts of your body?
No,
Do you have any night sweats?
no.
Do you have any diarrhea?
Um, no,
Uh, do you uh, do you have any constipation?
no. I actually pass motion one day once.
Okay, all right. And do you notice any skin tightening around your fingers or around your face?
No.
Okay. Do you notice any troubles with your urine? Any frothy urine?
Oh, about my urination, I'm actually a dialysis patient. So, I'm on regular dialysis. So I has been having no urine for the past 5 years.
I see. Okay. Um, and do you notice any chest pain?
No chest pain.
Okay. Do you notice do you notice your appetite has reduced?
It's because of the pain that I'm actually don't feel like eating.
Okay. So just going back to your past medical history, and you said that you're a dialysis patient for the past 5 years.
Yeah.
How are you dialysing?
I'm actually using a fistula, and I have been using it for the past 5 years, which is over my left forearm, and so far it's functioning well.
Okay. And you dialyze 3 times a week?
Yep.
And are you under a regular follow-up under a nephrologist?
Yeah. The nephrologist actually last reviewed me about 2 months ago, and everything seems good that time.
Okay. And do you have any other medical conditions that I should be aware of?
Oh, I do have diabetes, and I do have this condition called atrial fibrillation, and yeah, and also this end stage this kidney problem requiring me dialysis.
Okay. And when was your atrial fibrillation diagnosed?
It was about 2 years ago.
Okay. All right. And are you on any medications for all 3 conditions?
Yeah, actually, my list of medication, I'm taking metoprolol twice a day. Then I'm taking calcium supplements, calcium carbonate 3 times a day, vitamin D supplements once a day, and gastric medication called pantoprazole. And also diabetes, I'm only on a single medication called gliclazide. And my last medication for my blood pressure is actually amlodipine.
Okay. And are you on any blood thinners for your atrial fibrillation?
The doctor told me that because I'm actually having end-stage renal failure, so not advisable to take this blood thinning agent. They actually advised me for an operation, but I actually refuse it.
Okay. All right. Okay. Do you have any medical conditions that run in your family?
Not that I know of.
Okay. And do you take any supplements or any traditional medication?
No.
Okay. Okay. Was there any change in the recent doses of your medication or any addition of new medication?
Not really.
Okay. All right. A question that we ask every patient, do you smoke
No. I'm not a smoker.
and do you drink alcohol?
No.
Uh, do you use a question I ask every patient, do you use any illicit drugs?
No, I'm not taking any party drugs or anything because I'm already 80 years old, 70 years old.
Yeah. Okay. And so a question that we ask every patient, how's everything at home?
What do you mean by how's everything at home?
Who do you live with?
Oh, I'm actually living with my husband. He's the one that actually sending me to the dialysis center 3 times a day, 3 times a week.
Living with your husband?
My husband.
Okay, all right. And a question that we ask every patient as well. Do you have intimate relationships besides your husband in the past few years as well?
No.
Okay, all right. Okay. Okay. Do you feel any numbness or tingling in your hands or your feet?
It was quite some time ago. But the doctor told my nephrologist told me that it was because of my diabetes.
Okay, all right. Any weakness that you experience standing up?
No. But for past 3 weeks, because of the pain, I have to actually use a wheelchair. And
Can
currently,
I
also still feel painful now.
can I take a look at your hand lesions as well and your trunk lesions?
The hand and trunk lesion is similar as this photo.
Okay.
Mm.
All right. And you said that there was no recent change or addition to your any of your medication.
No.
Okay. All right. So I would like to examine the patient now.
All right.
Yeah. So firstly, I'll take a look at the rash and check for any discharges, active discharges, or any bleeding.
Okay. As you can see, the picture on the left side is the right leg of the patient. There are some granulation tissue and also some slough, but there is no active discharges seen.
Okay.
Mm.
And I also like to check for any finger prick marks.
Yes, there are fingerprint marks.
Okay. I would like to offer fundoscopy to check for any diabetic retinopathy.
Examiner say no need.
Okay. Sorry, I'll just ask some questions as I examine you. With regards to your diabetes, do you know how is your control of your diabetes?
Oh, actually, I have frequent low sugar for the past 3 weeks also. My sugar actually when I check in early in the morning, it can go as low as 4, and then I will feel very hungry as well. That's why I've been stop taking my diabetes medication.
I see. Okay. I see. Do you know your HbA1c or your 3 monthly sugar?
Last check was about 7%.
7%. And I'm just going to examine the eyes to look for any conjunctivitis.
No conjunctivitis.
Examine the oral cavity for any ulcers.
No abscess ulcer.
Mm. Um, so I just want to clarify, your symptoms of low blood sugar only started these 3 weeks, and previously you did not have any problems with that.
Previously, maybe 1 month once, but for the past 3 weeks, I have been experiencing quite frequent and needing me to stop the medication.
Okay. And do you take any medication to replace that?
Whenever I feel hungry, I will just take a small candy.
Okay. All right. Okay. Do you have any vomiting?
No vomiting.
Okay. I'd just like to listen to the heart to listen for any murmurs.
No murmurs.
Listen to the lung bases as well to hear for any crepitations.
Okay, good. No crepitation.
I'd like to feel for the
2 minutes left.
dorsalis pedis pulse.
Dorsalis pedis pulses are palpable, both sides.
Okay. Can I ask Madam Wong, do you have any concerns?
Yeah, doctor. Could this be an infection?
So after I examined you, this looks like there is some infection going on with both of your lower legs. However, I also want to rule out other symptoms, other syndromes as well. So I would like to refer you to a skin doctor as well.
Mm-hmm. Do you think will there be scars after the wound are healed?
So it depends on the underlying etiology. However, if I suspect a condition that's called sweet syndrome, so uh, it would most likely recover after that.
Okay, may I know what is sweet syndrome, doctor?
It is condition. It is condition where there is inflammation of your skin. Yeah.
Okay, and how to prevent it if you mentioned that I have this sweet syndrome?
I'll check back with that and get back to you later.
Okay, doctor, I'm actually in severe pain now. Can I request for morphine?
Okay, so we will try with some other pain
Time's
medications
up.
first to try to control your pain.
All right. Okay. Question. Diagnosis?
So my primary diagnosis for this case will be sweet syndrome.
Mm-hmm.
My second differential will be pyoderma gangrenosum. However,
Okay.
there's no other symptoms of IBD.
Okay.
Third diagnosis will be SJS or Stevens-Johnson syndrome.
SJS. Okay.
Yeah, that's my
What will be your
differential diagnosis.
investigation?
So I would like to send off a full blood count, a CRP as well as ESR to look for signs of infection and inflammation. Send off renal profiles as well as liver function tests prior to starting any drug therapy. And I would also like to refer to dermatology for a skin biopsy.
What else would you like to take?
I'd like to perform a Doppler of the bilateral lower limb as well to access the arterial supply.
Okay. What will be your management?
So, depending on the underlying etiology, I would like to manage this patient firstly by non-pharmaco, and provide dressing for the ulcers, and as well as any desloughing for any slough on the lower limb, and also provide pain management for the pain that the patient is experiencing, and also refer to a dermatology unit for skin biopsy.
If it's a sweet syndrome, do you think you will need a skin biopsy?
Probably not.
Okay. What other condition associated with pyoderma gangrenosum?
It can be associated with inflammatory bowel disease
Some more?
and not very sure of that.
All right, it's okay. Okay, suppose this patient is taking warfarin. So what will be your differential diagnosis?
It can be calciphylaxis secondary to warfarin as well.
Calciphylaxis. Okay. All right. Besides calciphylaxis secondary to warfarin, what else? If let's say the patient newly started on warfarin.
Not very sure though.
Okay. So how would you treat calciphylaxis?
I would like to stop the offending drug, which is warfarin.
Some more? This patient is also on other thing, other medication.
As well as the calcium supplements as well,
Okay. And
vitamin D.
okay. Any other medication you know can help to treat calciphylaxis?
Not too sure.
Okay. If it is due to bacterial infection called Pseudomonas, what will be the skin lesion called? Do you have any idea?
Not very sure.
All right. Okay. How would you check for adequacy for hemodialysis in this patient?
I'd like to examine the patient's fluid status, so that to make sure that the patient is not overloaded. And also there is check the renal profile as well, to see whether to look at the urea, the potassium, and the for acidosis.
Some more? From physical finding.
No. Yeah.
Okay. All right. This scenario is actually a bit difficult, but this is real patient also from my hospital lah. Okay. How do you feel?
I was very unsure about the diagnosis, so I find it very hard to continue to give management.
Yeah, actually, in the end, you actually got the diagnosis, you know. It's calciphylaxis.
Oh, okay.
Yeah. And calciphylaxis doesn't necessarily happen in patient on warfarin only. it is more common in there are actually some risk factor associated with a calciphylaxis, and most common it happens in end-stage renal failure patient.
Oh, yeah.
Yeah, so that's why I actually try to help you, but somehow you deviate further, then after that you come back again. Then you deviate further again, then I come back again. Okay. So how I would mark you is that later I will tell you the answer the question I asked you. The clinical communication skill, again, you quite okay. You can get quite some ask most of the question. You ask about the MO, but the important thing is about the skin rashes. You ask about when it started, but how it started, did you ask?
No.
How it started, did you ask? That is there any pus? I say it's a yellowish discharge, no bad smell, but it doesn't mean that it's not pus. And then did you ask about any insect bites or any trauma before that? I don't think you asked, if I'm not mistaken. So you need to ask a little bit more about the rash itself before you go into other thing. The rash, I think you spend less than 1 minute in asking. Then subsequently you straight away jump to the next thing already. So is the stem is skin lesion. So you didn't actually further explore the skin lesion, then you jump to other history already. It's a bit too fast. Then in second I can, in the next minute, I know you are starting to ask about vasculitis. You start to ask about the CTD symptoms and also the IBD symptoms already. It's a bit too fast because you didn't actually ask everything about the rash. So that's why this one I will just give you borderline. Then for physical examination, you need a lot of prompting. So if you don't know what to do in an end-stage renal failure patient, you can examine like a abdomen station also. So you can examine the patient fistula, you can examine the patient adequacy, you can check for any uremic flap. It could be just a uremic skin lesion. So you can examine many things else rather than the long pause. If you don't know how to comment about the skin lesion, at least you know that it's an ulcerative lesion with a raised border and also sloughy on the right side. So if you want to be more detailed, I wouldn't ask about like how many cm times how many cm. You just say it's about what size. Then you did offer about checking the eye, everything, which is good. Look for DM dermatopathy also, which is good also. But I feel like your physical examination is not complete, it's a bit here and there. So I will also give you borderline. For your clinical judgment, because you didn't get the correct diagnosis until the end, so there's appropriate investigation that actually you miss out, which is very important in this case. Luckily, you mentioned about skin biopsy, which is good because in all most skin condition, you eventually most of them need a skin biopsy lah. So this one I will also give you a borderline. But managing patient concern, I keep telling you I'm in pain. I think I mentioned it 3 to 4 times before the concern. So I also mentioned that I'm in pain now. So you actually didn't address the concern of the pain. You didn't offer analgesia. Can you continue with the session? Will you like a painkiller now? So it somehow make the examiner feel like you neglecting the patient concern of the pain. So until the end, the concern is, can I get a morphine? So is neglecting the patient concern. For this, I will give you unsatisfactory because pain is very important. You need to address it immediately. If the patient, just like similar in com skill, if the patient is crying, you need to address it first. You cannot keep talking. Okay. Then identify physical sign. Okay lah, you get most of the physical sign correct. So satisfactory. Differential diagnosis. It will be borderline because in the end only you mentioned calciphylaxis, and one of the differential that I mentioned is that if it's a pseudomonas infection, it's a bit deep, but the diagnosis when a patient have a pseudomonas infection is called ectyema gangrenosum. So it's also gangrenosum, but it's a different type of gangrenosum. Then maintaining patient welfare, I would say it will be closely related with the concern. So I can only give you a borderline because you didn't really keep the patient pain-free. It's more like you're trying to ask more, but you didn't address the concern and also manage the pain. That's why it's very important. If you don't know the diagnosis, you need to address, at least you don't lose your mark in other places. Okay. So
Okay.
for this condition, the positive will be a painful skin lesion. It started with a small nodules, then it became an ulcer. Then the underlying patient have DMAF, ESRF on regular dialysis for the past 5 years. The negative will be non-photosensitive, no trauma, no new drugs, no uremic symptoms, no overload symptoms, no CTD symptoms, and patient have no IBD symptoms as well. The drug history I mentioned to you all, and social history is a non-smoker, is a non-alcoholic. So the sign you need to look hard is fever, because if the patient is having fever, it could be due to a bacterial infection, systemic infection, or it could be due to a secondary infection on top of the calciphylaxis. And you need to describe a little bit on the skin lesion. Is ulcerated, is a raised border, and there's actually slough. Then about the adequate dialysis, you need to check for uremic flap, JVP, and auscultation. I think this one is quite common. And I think you got quite some time, so you need to do it and check for the HDSS. Although I told you that I have no problem with the fistula for the past 5 years, but showmanship, you still need to show that, okay, this is the fistula, then it's functioning, then there is a trail, and the bruit fell, and recent bleeding mark, all that you need to tell. Then the diagnosis for this gentleman is, this lady is actually calciphylaxis. The differential is pyodermal gangrenosum, ecthyma gangrenosum. It could be a vasculitis or even a cellulitis. So for investigation-wise, baseline blood, coagulation profile is important because hypercoagulable state is actually associated with calciphylaxis, and calcium magnesium phosphate level and the PTH level is important because high PTH and also high calcium is the main problem with the calciphylaxis. Although not all calciphylaxis patient has not raised calcium level, and skin biopsy. So if you have mentioned skin biopsy and you got a diagnosis of calciphylaxis, the next question I will ask you is, what would you expect to see in the skin biopsy? So you are expected to see calcified vessels, especially the small and medium size vessels on the HPE, and also it will be negatively stained for all the immunoglobulin. Then management-wise, most important, stop calcium supplement you mentioned, and the calcium-based phosphate binder. You need to change to a non-calcium-based phosphate binder. Then vitamin K plus minus. If the patient is on warfarin, then probably stop the warfarin, start vitamin K. If the patient is not on warfarin, you can also give vitamin K, but the study actually is debatable, the result. And the medication that is off-label use, but it is actually in the guideline, is actually called sodium thiosulfate. It can reduce the progression of the calciphylaxis, and it can ease with the pain. Then importantly, wound care and analgesia. Make sure the pain, because I keep asking you, keep telling you I'm actually in pain, but you actually didn't offer me an analgesia until the end when I asked for a morphine. Okay, for concern, I think technically you answer most of it. Is this an infection? Calciphylaxis is not an infection, but it can have a secondary infection to it. In severe pain, can I have a request morphine? Again, we have to go by pain stat ladder. So PCM doesn't work, then probably opioid, some low dose opioid like tramadol, or if it doesn't work, then fentanyl, then morphine. Then you can actually say, I can actually offer you to refer to the APS team. Will there be scars after the wound is healed? For calciphylaxis, unfortunately, it is a yes. There will be scar, it will be scarring. But how to prevent it is to stop all the supplements and offending drug. But to be honest, calciphylaxis itself carry a very high morbidity and mortality rate. And the reason is that it can cause infection easily, and the disease itself, calciphylaxis, doesn't only involve the skin, it can involve all the organs as well. So by the time it actually manifests on the skin, the prognosis is actually not that good already. Okay, it's not a simple scenario. I need to say it's not a simple scenario, but you need to go more systematically. Okay, any question?
No.
Okay, if no question, Jimmy, anything you want to add?
Yeah, my question to Aaron is, why do you offer sweet syndrome?
Yeah, actually, I want to ask, why offer sweet syndrome? Sweet syndrome is actually arthritis or ophthalmic in manifestation, and I actually say don't have.
Yeah. I was looking at the skin lesion that I was It looks very fluffy, and then I was thinking of pyoderma gangrenosum or yeah, sweet syndrome. I'm not very sure.
Hello? Yeah, so for you to mention Sweet syndrome, you must have encountered before, right?
Yeah, I think there was once that I saw.
So usually what we
But
encounter will be mentioned in the exam and may not be the correct answer sometimes. So my question to you is perhaps a very simple one for everyone as well. When you encounter a skin lesion, be it ulcerated, be it flat at the level of the shin, bilateral shin, what is your possible differential diagnosis?
it can be venous insufficiency.
Mm-hmm. I mean, not
Can be
not to mention the first one. I mean that varicose vein, venous insufficiency, that would be like no much of lesion, like just like tortuous vein, right? But let's say got lesion like that, like just now, it's a bit ulcerated. It can be nodular. What are the possible thoughts? Yeah, you mentioned that this can be pyoderma gangrenosum. Definitely. Anything else? You also mentioned about CUA, right? Calcemic uremic arthropathy, which is the arteriopathy, which is the calciphylaxis. Anything else? If let's say not so angry looking,
mm, not
it's so
erythema
painful.
nodosum.
Yeah, erythema nodosum must be in your thought. Erythema nodosum can get infected, become secondary infection as well. And you mentioned about ethyloma gangrenosum is also possible. And I just want to show one more photo, if I can. Yeah, let me just this will not take over as the main presenter. Oh no, I share
I
one
stop
photo for a while, yeah?
I
Yeah.
stop there first. Okay.
Yeah, can anyone see this photo? I think can see, right?
Yeah.
Yeah. What is the thought? Anyone have any idea of this lesion? Also at the shin, bilateral shin. Okay, I think you can share back your screen. This photo is not very present as well. But anyway, anyone have any thought about this skin lesion? Yeah, someone mentioned in the group, right? Yeah, necromyosis lipoidica diabeticulum is also a possibility, especially for diabetic patient. Let's say got shin lesion, but unfortunately, this is not the lesion that I mentioned. So if you happen to see any of the patient, that patient is diabetic, but it's not diabetic dermopathy, that lesion is actually called prurigo nodularis. Okay, so when you see a patient with a chronic either liver disease or kidney disease, they will have this kind of lesion, like very nodular structure and diffuse over the both sides of the body, and this is actually what we call as prurigo nodularis. In I mean, the reason I'm mentioning that is just to widen your differential diagnosis when you encounter any anterior skin lesion lah. Gizon On also mentioned about necromyosis lipoidica diabeticurium is also one of the possibility. Therefore, it's order in exam, right? For derm station, like not many skin condition can come out actually. You need to differentiate between bullous pemphigoid and pemphigus vulgaris. You need to differentiate this anterior shin lesion thingy, and perhaps some other drugs, exanthema, like what you mentioned, Steven Johnson. But Steven Johnson cannot come out in exam lah. Maybe it can only come out like as a form of com skill instead of actual patient. I don't think it's fair to give a Steven Johnson, but drug-induced exanthema is also something that we need to consider as a and some other rare but can come out in exam. Those kind of skin condition is like mala rash, or because it can often lead to this drug-induced lupus. For example, hydroxychloroquine or any form of drugs that can cause lupus, and also those like systemic association like SLE or scleroderma, but not many skin lesion. You can see that the skin station for this consult is actually very less. And Yi Hong actually chose a very difficult station. I feel. Yeah, I feel it's difficult. I mean, CUA is something we must keep in the back of our mind if we encounter any end stage dialysis patient. non-healing ulcer may start off with any drugs used, especially in warfarin, may or may not associate with warfarin. And he did mention about this sodium thiosulfate, which is, anyone knows what are the other use of sodium thiosulfate? It's not commonly used, right? But there is one specific thing that we will use for sodium thiosulfate.
For the general anesthesia?
Huh? Sorry, what?
For the-
Anesthesia?
No, no, no.
Anyone have any idea? Yeah, correct. Cyanide toxicity. It's an antidote for cyanide toxicity. Okay, but anyway, it's not, it won't come out exam. This is something just for everyone knowledge. Okay, let's just proceed with the last case. Yo.
All right. So last case is Dr. T. Are you around, Dr. T?
Yeah, I'm around. Yeah.
Okay, so you'll be given 4 minutes, and we shall start the 4 minutes now.
Thank you. Okay, 4 minutes up.
Okay. So, hi,
Okay.
can start now.
Mm.
Yeah. Hi, I'm Dr. T, doctors in the medical admission unit. Nice to meet you. May I confirm your name is Mr. Ahmad, 25 years old?
Yeah, doctor, I'm Ahmad here.
Okay. So it comes to my knowledge that you're having this constipation for the past 3 months. Can you tell me more about it?
Yeah, doctor, actually having a difficulty to pass motion for the past 3 months. Initially, previously actually pass motion every day once, but for the past 3 months, I realized that I only pass motion sometimes maybe up to 3 days once, and it's actually having some hard stool whenever I pass motion.
Okay. Is it the first time you're having this kind of episode?
Previously, I on and off I did experience some difficulty in passing motion when I was a few years back, but it actually resolved after I took some high fiber diet and also drink more water. But recently, this similar intervention actually doesn't help.
Okay. So does for the past 3 months, you mentioned that you have linked this difficulty in passing motion. Is it worsening, or is it gradually worsening? How is it?
I think it's rather static, and it doesn't actually appear to have worsened much.
Okay, all right. So beside you having this difficulty passing motion, do you get any loose too?
No loose stool.
Okay. What is the color of your stool?
It's usually dark brown.
Hmm. Okay. Is there any blood or mucus on your stool?
No,
Okay. All right. Um. Okay. So besides that, do you have any tummy pain?
yeah, on and off, I do feel some tummy pain, especially whenever I feel hungry.
Okay. So regarding your tummy pain, what does the tummy pain more worsen? Do you do anything to make it one more worsen?
As mentioned just now, usually when I feel hungry, the pain will be
Mm.
more severe, and after I actually take some food, then the pain will temporarily resolve, and subsequently it will just goes off on its own.
Oh, uh, can you pinpoint to me where is the site of your tummy pain? Is it at the upper part or central part or the lower part?
It's actually at the upper part.
Okay. During having tummy pain, do you have any feeling of a heartburn sensation? I mean, your burning sensation over your chest region?
No,
Okay. Do you have a feeling throat or feeling nausea?
no.
Okay. All right. Um. Regarding your difficult in passing motion, do you have the feeling you have this difficult to control your motion? You have to urgently go to the toilet to pass your motion, or you can control it?
Oh, I can control it. In fact, I have to strain when I pass motion nowadays.
Okay. Do you have this feeling of this after you're passing out the motion, feel like something is still is incomplete of passing out all your motions?
No.
Okay. All right. Just want to screen through a few questions.
Hmm.
Yeah. Um, Recently, do you took any medication?
I only took this stool softener to help me pass
Hmm.
motion.
Okay. Does it help?
Initially, yes, but I think lately it doesn't really help anymore.
Oh, okay. All right. No worry, Mr. Ahmad. We are trying to help you at the end of the conversations. Okay. Just want to ask a few questions. Do you have sustained a few associated symptoms? Recently, do you have any weight change?
Oh, no change in my weight.
Okay. How is your appetite?
My appetite is the same.
Hmm. Okay. Does you have any, preference to any weathers recently? You prefer hot weather or cold weather recently?
No,
Is there any tremor of your hands?
What is tremor, doctor?
Oh, sorry, shaking of your hands?
No,
Or do you notice that any sweat, your palms is sweaty recently?
no,
No, okay. All right. Do you notice any lumps and bumps in your body?
no. Oh, I do realize that actually, I feel like my neck have some is getting bigger, slightly swollen, but there's no
Okay.
pain on it.
Okay. All right. Okay. When does you notice it? When does it started?
Probably about 6 months.
Okay. All right. Does it calling you have a difficulty in swallowing or any,
Oh no,
or do you have any difficulty in breathing?
no,
All right. Do you have any back pain recently?
no back pain.
Okay. Um, does anyone notice that you are recently look more pale? They
No,
notice you are, I mean, you are look more pale recently. All right.
no.
Okay. You recently do you have I mean feeling very thirsty and passing out a lot of urine recently?
Yeah, now when you mention, I feel slightly, I drink more water, but I also pass out a lot of urine.
Oh, when does it started?
I'm not too sure, doctor, but probably after the constipation started.
Okay. You mentioned that you doesn't have any bony pain, right?
No,
Any side of your pain. Okay. How is your mood? Is there any change in your mood recently?
oh
Anyone
no,
notice that okay. All right. Um, does you have any recently have this episode of this you feeling like you feel like your face becoming more red and have a flushing of your face?
occasionally I will feel hot, flushing, but it just resolved on its own. I'm not sure it's because of the weather changes or what.
Okay. All right. Um, do you have any headache recently?
No headache.
Okay. Do you happen to check your blood pressure recently? Is there any yeah, do you have
No, because previously I was healthy, so I actually never check any blood of my blood pressure.
okay. You also mentioned that you doesn't have any passing out any loose stool, right?
Yep.
Okay. Just want to ask further history. How is your diet, Mr. Ahmad? What do you take normally?
I take a normal balanced diet. I didn't have any food or vegan preferences.
Okay. Okay. Do you choose any food? I mean, do you took vegetables and fruits?
Yes, I do take them on some normal amount, I would say.
Okay. All right. Can you recently do you have any night sweats? I mean, sweating and over the night?
Oh no,
Okay. So you mentioned that you took some stools of softener. Do you took any other medication? Example like traditional medication or you bought or over the counter?
no,
Okay. Do you have any known medical illness, Mr. Ahmad?
not that I'm aware of.
Okay. All right. Any disease running in the family that need to take note of?
Actually, my father have a problem with the kidney. He told me that the doctor told him that he have some kidney stones.
Mm,
Mm.
okay. So besides does your father seek any treatment or on any medications for the kidney stone?
He underwent some what the laser therapy for the stone.
Mm.
Mm.
Oh, okay. Okay. All right. I need to ask a few questions just to run through. Do you have any racing of your heartbeats?
No,
Do you have any chest pain?
no,
Okay. Do you have any blurring of your visions?
no,
Do you have any abnormal movement or fitting episode occur?
no.
Okay. How is your urine? is there any, frothy, your swelling is bubbling or any blood in your urine?
No.
Do you have any joint pain or any rashes?
No.
Okay, all right. What did you work as, Mr. Ahmad?
Actually, now I'm a clerk.
Okay, all right. Just want to ask some sensitive questions just to make sure that I did not miss anything. Do you smoke?
No.
Do you take any alcohol?
No.
Oh, Mr. Ahmad, are you single or married?
I'm single.
Okay. Just want to ask you some sensitive question because it's related to your. It can help me to come to a conclusion for you. Do you in any time involved in any unsafe, intimate relationship with any other person?
No.
Okay. Do you took any party drugs?
No.
Okay. Mr. Ahmad, can I examine you?
Sure.
Yeah. First of all, I would like to examine the general patient. Is patient look like sick?
Patient is of normal build.
No, no. Okay. I would like to check for the pumps. Is there any sweaty pumps or any tremor?
No sweaty palms, no tremors.
How is the pulse?
Pulse is regular.
Okay. All right. I would like to check for the eyes.
Mm-hmm.
Is there any pallor, any jaundice?
No pallor, no jaundice.
Okay. I would like to look at the eyes. Is there any proptosis or any ophthalmoplegia?
No thyroid eye signs.
All right. I would like to examine the neck. Is there any swelling that I may know of?
There is neck swelling, which is
Oh.
about 4 times 5 cm.
Okay. Is it diffuse or just nodular?
Diffuse.
Diffuse. Is it tender?
It's non-tender.
Okay. I need to make sure that it's a thyroid. So I'll ask the patient to swallow. Is it move with the swallowing?
It moves with swallowing.
Okay, and then it drops or protrude with the okay. Then I would like to examine the thyroids. Sorry, I'd like to examine the abdomen. Sorry.
Okay.
On inspections, is there any scars or any lesions
No
can be seen
scar.
on the? Okay. I would like to palpate. Is there any mass palpable?
No mass palpable.
2 minutes left.
Okay. Any pollutable kidneys?
No palatable kidney.
Okay. Is there any lower limb swellings?
No lower limb swelling.
Is there any lymph nodes palpable?
No lymph nodes palpable.
Okay. Hi, Mr. Ahmad. Hi, Mr. Ahmad. Do you have any concern?
Yeah, doctor. My frequent urination has been causing me to have problem with my work. How to settle it?
Okay. So, from the conversation and after I examine you, I think that your this difficulty in passing motion, it could be due to some electrolyte imbalance. We call it, I think that your calcium is high, but I would like to confirm it by checking your bloods first. And because you also have this obvious thyroid swelling. So I think of this it's called multiple endocrine neoplasia. Don't be afraid of this word. Have you heard of this word before, Mr. Ahmad?
No, but it sounds scary.
Okay, you don't need to worry, Mr. Ahmad. We are trying to help you. So, this multiple endocrine neoplasia, why do we come to this point? Because your father also had these similar symptoms. Then you have these symptoms caused by this high calcium. So it might be related to this multiple endocrine neoplasia. It's kind of consists of this your parathyroids and in as well as some pheochromocytoma, which can cause you to have a high blood pressure and your flushing, and then it could be due to, could be related to your sorry. So but before we come to that, we need to further work out. Then we will try to help you and treat all those complications that occur from this multiple endocrine neoplasia.
Oh, doctor, is this a cancer?
Okay. Cancer it
Nice
could
up.
yeah. Yeah. Should I
Continue.
Oh yeah. Yeah, it could be cancer could be one of the possibility because there is an obvious mass over your thyroid, but we need to further investigate by carrying some imaging and scan over your thyroid and carry out some blood tests. However, it might be related to your family. We might also need to screen for your family as well. We are trying to help you. Yeah, cancer is part of the possibility.
Is it something curable?
Okay. It's something is not multiple endocrine neoplasia is not something curable, but we able to control it. I mean, treat any complication occur, and then yeah, we're able to control it, but it's not something curable.
Okay. Doctor, will I die?
Okay. Because if we diagnose it, I mean, we diagnose it earlier, then we can know what is it about. Then we can treat all those complications. Then we can prevent all these. You can prevent all these dying on. Yeah.
Actually, I'm quite worried that I will become like my sister because she also have some similar complaint prior to that. Then subsequently, he actually have some mood disorder, mood problem, causing her to be needing to take some medication from the mood doctor and also the psychiatrist. Will this similar thing happen to me as well?
Okay, so because all these multiple endocrine neoplasia, it can cause your calcium to be high. So when your calcium is too high, it can affect your mood symptoms. So if we notice it earlier and we can control your calcium level, then we might prevent it from happening. Mr. Ahmad, is it okay for you?
Yeah. All right. Now I understand. Okay.
Yeah. Mr. Ahmad, do you have anything you want to ask me?
I think that's all.
Hands up. Okay, thank you. Yeah.
Okay. Question. Diagnosis?
Multiple endocrine neoplasia.
1 or 2?
2.
2A or 2B?
2A.
Reason?
Okay. First of all, patient had these hypercalcemia symptoms. It could be due to this parathyroid hyperplasia, and then patient also I think patient having this pheochromocytoma. But patient doesn't have any episodic headache. But occasionally he got this episodic of flushing. So I believe patient had fulfilled this criteria for pheochromocytoma and parathyroid hyperplasia with a positive family history of father and sister. So yeah, so it's very likely to be multiple endocrine neoplasia type 2A.
How do you investigate it?
First of all, I will run some basic blood investigation such as full blood count, renal function test, calcium albumin phosphate, IPTH as well, and thyroid function test to check for the thyroid, check for the calcium level, and check for the IPTH, which can cause hypercalcemia. Then for pheochromocytoma part, we can send for the 24-hour. No, it's sorry, I'm confused already.
How about medullary thyroid carcinoma?
Yeah, for the medullary thyroid, we need to send for the calcitonin and check for the function test and arrange for the ultrasound neck to confirm it. Yeah. and
Okay.
maybe arrange for a biopsy for it.
Biopsy. Okay. How would you confirm there is a parathyroid involvement besides IPTH?
We
Hands
can
up,
carry
I
out
can
this
confirm it.
we can carry out this seismotomy scan.
Okay. Management. How would you manage this gentleman?
First of all, I need to admit this patient. I need to run this a few blood investigations. If you confirm patient have this hypercalcemia, then I need to run hydrations to correct the hypercalcemia. If it's not responding to the hypercalcemia, then I need to start this biphosphonate therapy for this gentleman. But besides that, I will need to involve patient education and counseling, and also involve multidisciplinary team for this. And I need to refer to the gland doctor as well, because this is related to the endocrine. And then I'll run some. I will carry out this genetic study to confirm this multiple endocrine neoplasia. Yeah.
You mentioned about genetic study. What is the gene that is involved?
Sorry, I forgot already. I can't remember. Yeah.
Okay. How about the medullary thyroid carcinoma? Medullary thyroid carcinoma. What would you like to do to it?
Okay. For medullary thyroid carcinoma, after we confirm with the ultrasound, I need to refer to the surgical doctor as well. If patient require any surgery to remove it, for the removal of the.
Okay. You mentioned that patient actually asked you whether it's a curable disease or not. Is a MEN2A curable?
I think it's not curable, but it's controllable. Yeah.
It's not curable, but it's controllable. All right. Okay. So, your differential diagnosis for this gentleman on the beginning, what would be your differential besides the MENS2A?
My differentials could be hypothyroidism.
Good. Some more?
It could be due to functional because of these constipations. It could be due to irritable bowel syndromes.
Okay. Some.
Then hypercalcemia.
Have you thought of chronic laxative usage?
Oh, yeah, chronic laxative usage also could be one of the
Causing the constipation. Okay.
Yeah.
What are the red flags for constipation?
We need to rule out those prostatic symptoms such as tenesmus and urgency to passing out the motion, unable to control. So this is we need to rule out this colon malignancy. And as well as we need to ask patient about constitution symptoms such as any loss of appetite and loss of weight, and any family history of colon carcinoma as well.
Okay. So, what do you think the sister actually have also?
The sister likely having these hypercalcemia symptoms because of this mood change. It could be due to this parathyroid hyperplasia.
Parathyroid hyperplasia.
Yeah.
You mean that it's hypercalcemia leading to the mood change?
Yeah.
Okay. All right. I think that's most of the question that I actually want to ask. Jimmy still got time.
It's already up. Time is already up just now.
Oh, okay. Sorry.
Thank you.
So, basically, you got the diagnosis lah, it's actually meant to A lah, So, history-wise is okay, is satisfactory. You got most of the question you want. Initially, I think I actually debate you to I think you are thinking of modulus hypothyroid, then suddenly come up with the polyuria polypsia, then okay, you come back to the hypercalcemia already. Then for physical examination is appropriate as well, because, but actually why you want to ballot the kidney, huh?
No lah, no. This, I think I don't need to do it. Yeah, maybe the time is now. So,
You need to ballot the kidney, you just palpate for any abdominal masses.
Yeah.
Okay. Clinical judgment wise, I think the investigation all are sensible and appropriate, but probably you need more confidence because you are a bit agak-agak lah. So this one, I think I'll give you a borderline, but concern, yes. Then physical signs also, yes. Other differential that you can actually offer is familiar hypocalciuric hypercalcemia, because it also
Yeah.
runs in the family also. Then you can also consider MAN 1 and also primary hyperparathyroidism lah. Then patient welfare also okay. So I think you'll just get a borderline from the clinical judgment lah. So for this patient, positive is constipation, on and off crampy abdominal pain, polyuria, polypsia, and the flushing. Not all patients with this patient actually don't have fever. The flushing is due to the medullary thyroid CA. Actually, medullary thyroid CA, their symptoms is not due to hyper or hypothyroidism, it's flushing and diarrhea. Most of them, the most common symptoms presenting complaint. Then the negative is a psychiatric symptom, no change, weight change, no thyroid symptoms, palpitation, episodic headache, GI symptom, vision problem, back pain, all I think you ask. Then family history, actually, if you ask whether one of the sibling actually have gastritis symptoms also. And in the end, I actually offer that the sister actually have mood disorder. So single unmarried as well. And I think you forgot one of the differential could be diabetes as well. Query control diabetes with DM autonomic neuropathy, polyuria, polydipsia, and then constipation. You also need to check for finger prick mark, but it is not a hard sign, but you need to look for it also. If you look for it, then the examiner know you are thinking of diabetes also as your differential. Then next really, thyroid sign, okay, abdominal masses and visual field. Visual field, the reason I put is that if you are thinking of MAN 1, then you need to check field, then you need to check for the hormonal panel as well. Then the differential, the diagnosis is MAN 2A, differential as mentioned. Then investigation wise, mostly you mentioned, but I will add on with a HbA1c for you because DM, you need to check, and calcitonin level, IPTH, vitamin D, ultrasound neck, histamine scan for the parathyroid hormone, ultrasound abdomen, and also adrenal. And for the physio, then is the 24-hour urine metanephrine you can send. Then management wise will be education, counseling, MDT, genetic. Genetic testing is to test for rat oncogene. The gene is called rat oncogene. Surgery, yes, medullary thyroid CA need to be removed. You cannot say, I will refer surgical, maybe need removal. Medullary thyroid CA need to be removed. Is a must. And is it curable or not? Actually, this disease is curable.
Oh, okay. All right.
That's why if it come out in station 4, you cannot say it's a not curable disease. It's a curable disease because you have surgery, you have medication, you can do gene testing, so it's a curable disease. Then about the frequent urination disturbing the work, I think you have to address that we need to treat the underlying, like you mentioned. Once we treat the underlying of hypercalcemia, the symptoms will resolve. But at this moment, probably like you mentioned, patient will need an admission to check for any hypercalcemia. If it's really hypercalcemia, the treatment will be like you mentioned, hyperhydration. Then if it doesn't responding, you need to give bisphosphonate. So this is actually in cases if come out constipation, then you need to think of hypercalcemia. Then under hypercalcemia, you miss out something. Not necessarily only these mans. Of course, they like to come out with the MAN 1, MAN 2, all, but you also need to think of, for example, other causes of hypercalcemia in Malaysia can be TB. In Western country, can be sarcoidosis. Then you need to think of malignancy, although it's rather young, not necessarily only GI malignancy, you need to think of myeloma, in which, okay, you ask about back pain all, but you need to think of myeloma all. Then second, you need to think of hypothyroid and also colorectal carcinoma, colorectal malignancy. So in general, this case, I think is rather common and it can come out in the exam one. Okay, I think that's all from
Thank
me.
you.
Junie,
Thank you,
anything?
Yeah, another thing I want to mention about the causes of hypercalcemia, right? Especially in elderly, we need to also make sure that the patient is not on calcium supplement. So sometimes patient or elderly on calcium supplement for bone protection can actually cause hypercalcemia and constipation. So this is another thing that we need to explore as well. Okay. And yeah, someone asked some question, right? I saw in the few words about sesame scan. Yeah, Yihong, please.
Sesame scan is actually to it's a radionuclear scan to look to it actually to detect the parathyroid. So you need to use a radionucleotide to actually do the scan, and it helps to locate and identify the parathyroid gland that is active and also enlarged. Yeah, it's a sesame scan.
Yeah. So in the olden days, it is called sesame scan. Now the newer term we like to call it like parathyroid scintigraphy, but essentially they mean the same thing. And my next question, perhaps to those that asked the question just now, is if the parathyroid scintigraphy is negative, but patient has PTH dependent hypercalcemia, will the patient still indicated for surgery? Anyone knows? Or want to unmute yourself to answer? So no one answer. I think everyone tired already. so perhaps everyone needs to know that if let's say you are dealing with primary hyperparathyroidism, the guidelines based on AAS, American Society of the Parathyroid Surgery Society, right? They are very clear. They say that if a patient has symptomatic primary hyperparathyroidism, even though the imaging is negative, you still need to proceed with exploratory parathyroidectomy. So meaning to say, why I say so is because parathyroid scintigraphy is only 70% sensitive, meaning 30% of the time the scan can be normal. And if you do ultrasound net, you may also miss out the parathyroid gland, which is very small. So eventually, the ultimate answer is which test or which modality is the best sensitive, best choice to actually detect for this parathyroid adenoma or hyperplasia is actually a surgeon's hand. Okay, and that's why exploratory parathyroidectomy is indicated. Okay, and there's also some other indication you all perhaps need to know just for knowledge, and maybe some, let's say, unfortunately, if you got some endocrinologists as an examiner and this kind of scenario, they may also ask a bit like, for example, what are the other options what are the other indications you will consider to proceed with parathyroidectomy in the patient with so-called primary hyperparathyroidism? Is when if it's a young patient, you mean the age of onset is like less than 50 years old, and that is a complication. So the keyword is actually not hard to actually remember. It is the complication for hypercalcemia. For example, complication in terms of renal. So how do you remember a complication of hypercalcemia? It's very simple, right? You want to use the mnemonic or those words like painful groans, moans, and all those psychic moans, like things like that. You can. But generally, the easier way for me to classify is very simple. You can classify the commonest is being the renal, bone, and then you've got the brain, and then the remaining one is actually the gut. Okay, so all these organ can be involved. So renal, we are talking about nephrolithiasis, renal stone, or we are talking about kidney calcification, nephrocalcinosis, or you're talking about CKD or kidney impairment, EGFR less than 60. And then let's say that bone, you're talking about osteoporosis, fragility fracture, or even like so-called early osteoporosis. And then if you're thinking about brain, you're thinking about neuropsychiatric or neurocognitive symptom. And if you're talking about gut, then you're talking about today's scenario, which is a constipation or even some tummy pain. But bear in mind that hypercalcemia can also cause two other manifestations of the gut other than your constipation, which is acute pancreatitis as well as your peptic ulcer disease. Okay, so that's why it's also important to ask about all these symptoms. If you remember, whenever you encounter a hypercalcemia patient symptom, you can go by all these end organ symptom to exclude the complication. At the same time, you can also ask about the symptom. So I feel that this is actually very easy to remember. Doesn't require much mnemonic. Because sometimes we forget psychic moan. What else? Or painful groans. Okay. So it's a bit difficult, right? So you just have to go with very simple and very structured. And Aya Nin 2 asks about why men 2 only hyperparathyroid and hypercalcemia, no symptom of feel. So Yehong, you want to answer this?
Yeah, actually, for men 2A, 90% of them have medullary thyroid cancer, 90 to 100%. Then for FEO, it's only about 50%. For hyperparathyroid, means that parathyroid hyperplasia, it's only 5 to 10%. So you not necessarily will have all three, because the FEO only about 50%, but most of them will have, because up to 90 to 100% will have the medullary thyroid CA. So you still cannot say that, oh, you must fulfill all three to say this is M2A. No, because not all will have each and every of them. As long as you have a medullary thyroid CA plus, maybe FEO or even hypercalcemia, parathyroid hyperplasia, then you can actually, with a family history and positive red oncogene, you can actually say as a MEN2A. And if you actually go to read MEN2A, they got down to it actually they can split it into a red oncogene positive, negative, and then if it's a positive but it doesn't fulfill the whole criteria, they will have a familial medullary thyroid CA. So it's actually quite complicated. But for you to remember, MEN2, 90 to 100% will have medullary thyroid CA, and only about 50% have FEO, and then about 5 to 10% have parathyroid hyperplasia.
Anything I want to highlight is that when Yuhong mentioned something about MEN2A is curable disease, what he tried to mean is that it is something like non-cancerous. Why I say so is because the moment you remove the medullary thyroid carcinoma, the remaining two, which is the pheochromocytoma as well as the second thing as well, parathyroid hyperplasia, right? Yeah. So these two are actually benign non-cancerous gland issue. So that's why when Yuho mentioned about so-called non-curable, it essentially means that actually it's a benign condition after you remove the medullary thyroid carcinoma. So that's the reason why he say that so-called curable. But having said that, all these patients still need surveillance, okay? Still need surveillance. And you all know about pheochromocytoma. Let's say they occur in exam. There's this rule of 10, right? I hope everyone remember. So 10% actually will become malignant, and 10% is the bilateral, 10% is extraordinal, and only 10% is familial, which is underlying under this category of MEN2A or 2B lah. But remember that there's always like 10% chance that this field can be malignant as well. So we when we want to counsel, especially in com skill, if you come out as a MEN syndrome, you want to mention about this to test your knowledge lah, basically in a way. Okay. Anything else, you?
Yeah, I think that's all.
No one have any question, right? Everyone is tired already. So perhaps thank you so much for joining. Thank you, Yihong, especially. Spent almost 4 hours, right? 11 o'clock. 3 hours. Okay. So I'll stop the recording. Everyone can leave the conversation slowly. We'll upload the recording tomorrow.